Today I'm going to start a very important topic, that is kidney. Preeti, have you finished physiology of kidney? Preeti or others, anyone can answer. Have you finished physiology of kidney? Am I clearly audible to all of you? Okay, and Neha and Rinzan, did you people attend the general pathology and hematology classes also? Okay, so, okay, Ujjwal is here, good. Okay. तो तुम लोगों की फिजियोलॉजी में किडनी कवर हो गई है. अच्छा, now Neha and who's this? Neha and Rinzan, you've not done. So you've not done general path and hemat. Okay. Okay, so okay, let us start with kidney. Where is Raghavendra? Raghavendra has not come. Okay, so Rinzan has joined recently. Okay, so chalo, let us start with the kidney. Let us start with kidney now. Okay, now before we start with kidney, okay, so I hope all the others are there who were there last time. So we'll start with kidney. Okay, now in kidney. Kidney is a very, very important topic. As I did general pathology with you people and I did hematology, we will be doing MCQs also. Okay, and if you have any queries, it's a very important topic. You please ask me. Okay, now let us see a little bit about the normal structure of the kidney. Now, very important. Let us see the normal structure of the kidney, which you already know. Let us see, look at the kidney, the normal structure. Okay, now if you look at this is the normal structure of the normal kidney, gross. So kidney has two parts, the cortex, this is the cortex of the kidney, and this part is the medulla. So this is the medulla. This is the medulla, and these, you know, if you look at the medulla is pyramidal shaped, or medulla is something like this. It is shaped like this. Medulla is like this. So these structures are also, this is called medullary pyramid, and you know that these are medullary pyramids, and the tip of the earth, this 2/3 portion of the medulla, 2/3 portion, the lower 2/3 portion, this is called the renal papillae. Okay, so we have Muskan also. Okay, good. So Muskan has also joined. Muskan, did you attend general pathology and hematology with me, or you also joined late? Muskan? Okay, so coming to the kidney, in kidney we have the cortex and the medulla. If you see this cortical thickness, if you look at the cortex is 1.2 to 1.5 centimeters in thickness. Rest all is the medulla. Medulla is triangular or it is pyramidal in shape, and the tip of the medulla, the distal 2/3 of the medullary pyramids, these are called renal papillae. And you know, this portion is the pelvis. In the renal artery enters through the pelvis, renal vein leaves through the pelvis, and then through the pelvis you have the ureter also going out. Okay, so now this is the structure of the kidney. Okay, then here now on this side I have the structure of the renal, what you call as of the Bowman's capsule. We'll come to this later. Let us first look at this. Now the functional unit, the structural and the functional unit of the kidney is the nephron. So this is the nephron here, what I have drawn, what you can see here. This is the nephron. So nephron, you know, there are nephron is the structural and it's the functional unit of the kidney is the nephron. Nephron is the place where the blood comes into the kidney, the blood gets filtered and urine is formed and urine goes out. Okay. So urine goes out. Okay, now if you look at the nephron, what do we have? In the nephron, if you look at this, I know you already know this, but I want to talk a little bit about this so that when we read glomerulonephritis and pyelonephritis, you know what is going on. Okay, now if you see this is called this structure, this portion is called the glomerulus, and this is the glomerulus capillary tuft. It is inside the Bowman's capsule. So this is the glomerulus. Then from the glomerulus comes the tubules. Tubules are of three types. We have PCT, then you have the loop of Henle, then you have the DCT. So this is the loop of Henle, then we have the DCT, and then we have the collecting ducts. You have the collecting ducts. So the tubules में क्या क्या parts हैं? We have the PCT, we have the loop of Henle, then you have the DCT, and then we have the collecting ducts. Now if you look at this structure, what part of the kidney lies in the cortex and what part of the kidney lies in the medulla? So if you look at the kidney, nephron, most of the glomerular capillary tuft and the PCT. So the glomerular capillary tuft and the PCT, they lie in the cortex. The glomerular capillary tuft and the PCT. Asad is asking me how much I got late. Okay, not much. I just started, Asad, so don't worry. Okay, now the glomerular capillary tuft and the proximal convoluted tubule, they lie in the cortex. Then if you look at the medulla, in the loop of Henle lies in the part of loop of Henle lies in the medulla. Then DCT again lies in the cortex. So PCT, DCT also lies in the cortex, and then collecting ducts lie in the medulla. So the glomerular capillary tufts, the proximal convoluted tubules, and the the distal convoluted tubules, they all lie in the cortex. What lies in the medulla? Most of the loop of Henle and the collecting ducts lie in the medulla. And you know, if you look at the medulla looks, it's triangular in shape as we saw, or pyramidal in shape. It looks like this. And if you see carefully, the medulla has these rays, what we call as medullary rays. These are medullary rays. In the medulla, you have these medullary rays. What are these medullary rays? These medullary rays are actually collecting ducts. All the collecting ducts, they open at the tip of the medulla. They open here at the tip of the medulla. So these medullary rays are actually collecting ducts which have collected all the urine, and they will empty it at the tip of the medulla. From here, the urine which is formed in the glomerular. So where is the urine formed? It's formed in the glomerular capillary tuft by filtration of blood. Then PCT, DCT, loop of Henle, they all have their functions to perform, which will be told in physio. Then the urine passes through the collecting duct. All the collecting ducts, they form the medullary rays, and then these collecting ducts empty into the renal pelvis on the tip of the medulla. So this is the tip of the medulla. So this portion, distal 2/3 of the medullary pyramid, is called the renal papilla. So I will talk about papillary necrosis. So what is papillary necrosis? The tip of the distal 2/3 of the medullary pyramids, when they undergo necrosis, that is called as papillary necrosis. So once again, if you look at the kidney, in the kidney we have cortex and the medulla. What is the cortical thickness? Cortical thickness is 1.2 to 1.5 centimeter. Rest of the kidney is the medulla, and this portion is the pelvis. So medulla किस तरह से होता है? Medulla is in the form of pyramids. Distal 2/3 of the medullary pyramids are called renal papillae. Then you have the renal pelvis. All the medullary pyramids, they open into the pelvis. In the pelvis, you have these. From the pelvis, the urine goes into the ureter and then the bladder and goes out. Okay, and then if you look at the functional unit of the kidney, which is a nephron. The nephron has a glomerular capillary tuft which is surrounded by a Bowman's capsule. Then the nephron has a PCT, it has a loop of Henle, it has DCT, and it has the collecting ducts. The glomerular capillary tuft, the PCT, the DCT, they lie in the cortex of the kidney, whereas the loop of Henle, most of loop of Henle and the collecting ducts lie in the medulla. They lie in the medulla, and these collecting ducts, all these collecting ducts, they give the medulla rays. They look like rays in the medulla. So this is called the medullary ray appearance. Okay, now let us come to this portion of the kidney. This portion is the glomerulus. You know, glomerulus can get inflamed. Inflammation of the glomerulus is called glomerulonephritis. So what is glomerulonephritis? अगर इस glomerulus की inflammation हो जाती है, if it gets inflamed due to some cause, that's called glomerulonephritis. Okay, now you know we have 1.5 million nephrons in the kidney. So you have lots of nephrons in the kidney. The functional unit of kidney is a nephron. We have 1.5 million nephrons. You know the nephrons can't hang loose in the air. All the nephrons rest on a connective tissue stroma. That connective tissue stroma is called the interstitium. So between the nephrons, what do you have? In between the nephrons, you have the interstitium of the kidney. What does the interstitium contain? So if you look at the kidney has the parenchyma. Parenchyma of the kidney are the nephrons. Where do the nephrons rest? All the nephrons rest on the interstitium. What is the interstitium? Interstitium is composed of connective tissue that supports the blood vessels, the nerves, etc. So now first inflammation of the glomerulus is called glomerulonephritis. Inflammation of these tubules. Tubules is PCT, Lupus-Fenley, DCT collecting duct. So inflammation of the tubules, tubules plus interstitium. So if the tubules and the interstitium, if they get inflamed, that is called tubulointerstitial nephritis. That's called tubulointerstitial nephritis. So the two terms that you have to understand is glomerulonephritis and tubulointerstitial nephritis. So what is glomerulonephritis? Inflammation of the glomerulus is called glomerulonephritis. What is the inflammation of the tubules and the interstitium of the kidney called? That's called tubulointerstitial nephritis. Okay, now very important, let us look at this glomerulus. If you look at this glomerulus, now let us look at this glomerulus. If you look at the glomerulus, now this is the Bowman's capsule, and here now we have these glomerular capillaries. These are the capillaries. So this is the Bowman's capsule. Bowman's capsule, and these are the glomerular capillaries. These are capillaries. You know what are capillaries lined by? The capillaries are lined by endothelial cells. These are the endothelial cells. So capillaries are lined by endothelial cells. So these are the endothelial cells lining the capillaries. So these are endothelial cells which line the capillaries, and these endothelial cells, they sit on a basement membrane. These endothelial cells sit on this is the capillary basement membrane. They sit on the capillary basement membrane. And now you have the Bowman's capsule. Now if you look at the Bowman's capsule is lined by two layers of cells. The inner layer of cells, these are called the visceral epithelial cells. So Bowman's capsule ka inner layer kya hai? These are the visceral epithelial cells. So it's lined by visceral epithelial cells, which are also called podocytes. Visceral epithelial cells or the podocytes. So the inner layer of Bowman's capsule is lined by visceral epithelial cells, which are also called as podocytes. And the outer layer of Bowman's capsule, the inner layer and the outer layer of the Bowman's capsule, this is lined by the cells here. These are the parietal epithelial cells. Parietal epithelial cells. And this area, this is called the Bowman's space. And this is where now urine is formed. Once the blood in the capillaries gets filtered, this is where the urine is formed, and then the urine goes down. And now here we have the PCT. So here we have the PCT. Now let us, very important point, let us see what is the filtration membrane of the kidney. So where the blood gets filtered and urine is formed. So now these three structures constitute the filtration membrane of the kidney. So if you see which are these three structures, I have drawn them far apart. They are all close to each other. The filtration membrane of the kidney is made up of, number one, the endothelial cells of the capillaries. Number two, the basement membrane of the capillaries. So capillary basement membrane, and three, the visceral epithelial cells or podocytes. So the filtration membrane. So filtration membrane kidney की किन तीन component से बनती है? सबसे अंदर क्या है? Inside we have the endothelial cells of capillaries. So endothelial cells of capillaries, 1. 2, inside the endothelial cells of capillaries, outside the endothelial cells, what do we have? We have the basement membrane of capillaries. And third, the filtration membrane is formed by the visceral epithelial cells. visceral epithelial cells. So this is where the blood gets filtered, urine is formed, and then this urine comes out into the Bowman space, goes down through the PCT, loop of Henle, DCT, collecting ducts, and then all the collecting ducts open at the renal papilla. From the renal papilla, the urine enters the renal pelvis. From the pelvis, it goes into the ureter, and then it goes down. So these are the filtration membrane. You know, filtration membrane is charge and size dependent. It filters substances based on their charge and size. Okay, so this is the filtration membrane of the kidney. So now let us look at, this was a simple diagram that I drew. So now let us see here, this is the renal corpuscle or the Bowman's cap, this is the glomerulus. So now if you see, what is the filtration membrane of the kidney formed of? This is the Bowman's capsule here. This is these, if you look at the Bowman's capsule, these are the parietal epithelial cells. Outer lining, these are parietal epithelial cells. Inside, these are the green colored are the visceral epithelial cells. Then these are the glomerular capillaries. Now if you see visceral epithelial cell, then you have the capillary basement membrane. This black colored line is the capillary basement membrane, and then you have the endothelial cells of the capillaries. You have the endothelial cells of the capillaries. And now in between these capillary tuft, what do you have? In between these capillary tuft, you have these cells which are called the mesangial cells. So here the diagram that I drew. Now where do you have the mesangial cells? If you look at this diagram, these are the, here we have the mesangial, between the capillaries, here we have the mesangial cells. So we have the mesangial capillary tuft. So this is the structure, this is the normal structure of the filtration membrane. So now what is the filtration membrane composed of? This is the filtration membrane of the kidney. So filtration membrane is composed of the endothelial cells of capillaries which sit on the basement membrane of the capillaries, and then below that we have the green colored visceral epithelial cells. They form the filtration membrane, which is a charge and a size dependent, which filters the blood, which filters substances based on their charge and size. So this is the filtration membrane. And then we have these PCT cells. Okay, if you look at PCT, PCT is lined by tall columnar cells with a brush border. This is the PCT. It is lined by tall columnar cells. It's lined by tall columnar cells, and these cells, they have tiny villi on their surface. So they have tiny villi. So this is what you call as the brush border. This is what you call as the brush border. So they are lined by a brush border. So now PCT has tall columnar cells. Then as you go down, the height of the cells becomes smaller and smaller. So loop of Henle is lined by flattened cells. Then DCT is lined by cuboidal cells, and then collecting ducts are again lined by flattened cells. So as you go down, the cells, the height of the cells becomes smaller. Okay, now another picture of this filtration membrane which you see here. So another picture, very important. So if you can see here, this is the glomerulus, glomerular capillary tuft. These are the efferent arteriole brings blood into the kidney. The efferent arteriole breaks into a number of capillaries inside the glomerular capillaries. Then these glomerular capillaries will filter the urine, and then through the efferent arteriole the blood will go out of the kidney. So now this is the filtration membrane here, which is again shown in this picture. If you see these green colored inside, these are the mesangial cells. These are the mesangial cells. Then between the capillaries, these are the mesangial cells. These are the capillaries. They are lined by this endothelium. This is the endothelial cells of the capillaries. You can see these brown colored are the endothelial cells. They sit on the basement membrane, and then here these blue colored, these are the visceral epithelial cells or podocytes. And you know these capillaries, in capillaries में जो filtration वाली capillaries है, इनमें छेद या fenestrations होती हैं, इनमें छेद होती हैं, they have fenestrations, and then outside what is shown with this big blue nucleus, this is the parietal epithelial cells. So this is the normal filtration membrane of the kidney. Okay, now let us come to, so with this little bit of background, first topic that I will be starting will be, I hope, the filtration membrane. So okay, if we want to diagrammatically represent this filtration membrane, I can represent it something like this. So I can represent it something like this. These are the capillary endothelial cells or endothelial cells. This is the capillary basement membrane. And third, this is the visceral epithelial cell or what you call podocyte. So this is a diagram which I will draw many times today. So this is the filtration membrane of the kidney. So if you see, it is the same thing. I have drawn the endothelial cells, I have drawn this capillary basement membrane and the visceral epithelial cell. And then here you can see these mesangial cells outside. So here I can draw, this is the mesangial cell. This is the outside, this is the mesangial cell. So this is the rough diagram of the kidney. So now let us come to the first topic. Okay, now first topic is glomerulonephritis. As I told you, what is glomerulonephritis? Inflammation of the glomerulus. So what is glomerulonephritis? Inflammation of the glomerulus. Glomerulus is called glomerulonephritis. Achha, now when we talk about glomerulonephritis, I will be talking about 3 or 4 terms which you have to know. Number 1, focal and diffuse. Focal and diffuse. 1, focal and diffuse. And second, the term that I will use is global and segmental. Segmental. Okay, now what do we mean by focal and diffuse? Okay, focal and diffuse refer to all the glomeruli of the kidney. So now, focal glomerulosclerosis or diffuse glomerulosclerosis. So focal means the term, so focal and diffuse first. What is focal? Focal is a disease which involves less than 50% of the glomeruli. So if there are 1.5 million glomeruli in the kidney, focal disease will be when less than 50% of these glomeruli are involved by the disease. So less than 50% glomeruli are involved. So a disease that involves less than 50% of the glomeruli is focal, and diffuse is disease that involves more than 50% of the glomeruli are involved. So focal is less than 50% of the glomeruli are involved. Diffuse is more than 50% of the glomeruli are involved. So that is focal and diffuse. So focal and diffuse refer to all the glomeruli of the kidney. So what proportion of glomeruli, how many glomeruli are involved? If less than 50% of the glomeruli are involved, it is focal disease. If more than 50% are involved, it is diffuse disease. Achha, second term is global and segmental. Now what is global? Global and segmental refer to one glomerulus. Now look at single glomerulus. In that one glomerulus, is the disease involving the entire glomerulus? That's a global disease. If the disease is involving only a segment of the glomerular capillary tuft, that's called segmental disease. So global disease is, global means the involvement of the entire glomerular capillary tuft. Glomerular capillary. So look at one glomerulus, capillary tuft. So the complete tuft. So if this is the glomerulus, these are the capillaries. Here, global disease means it is involving all of them. Global disease means, global and segmental refer to one glomerulus. So global means the entire glomerular capillary tuft is involved, and segmental means only a segment of tuft. So disease is, so segmental means if these are the glomeruli, only this much is involved. So rest of the glomeruli are spared. So segmental is involvement of a segment of glomerulus by the disease. So involvement of segment of glomerulus by the disease. So these are 4 terms which you have to know, that is focal and diffuse, which refer to all the glomeruli. If the disease is involving only a proportion less than 50% of the glomeruli, that's a focal disease. If it is involving all the glomeruli or more than 50% of the glomeruli, it's a diffuse disease. Then if you look at one glomerulus, if the disease is involving the entire glomerular capillary tuft, that's global. If the disease is involving only a segment of glomerular capillary tuft, that is a segmental disease. Okay, then we will be using the word proliferative. Now when the term proliferative comes, what is proliferative? Proliferative means the glomerulus looks very, very cellular. So hypercellular glomerulus. So when the glomerular capillary tuft looks very cellular, it looks as if lots of people are sitting, more than normal people are sitting inside the glomerulus, we call it hypercellular. So we call it proliferative. So I will say membranoproliferative, acute proliferative glomerulonephritis. So when we use that term, that is proliferative. Then membranous. The term membranous. Now the term membranous. What is membranous? When we use the term membranous, membranous means it refers to the glomerular capillary basement membrane. Now if you see which is the basement membrane, glomerular capillary basement membrane, this is the capillary basement membrane. So this is the basement membrane of the capillary. So when I use the term membranous, I am implying, or I am trying to tell you that this basement membrane of the glomerular capillary tuft is, or this basement membrane of the glomerular capillaries is thickened. So this basement membrane, it is thickened, so it has become thickened. So what does the term membranous mean? Membranous means thickening of the glomerular basement membrane. Thickening of the glomerular basement membrane. So the basement membrane of the glomeruli is thickened. So what is the term membranous mean? The term membranous means that the basement membrane of the glomerulus is getting thickened. So that is the term membranous. So you have to know these terms, very important. Okay, now if I write focal segmental glomerulosclerosis. So what does this mean? It means focal, that means okay, segmental glomerulosclerosis. So the glomeruli are getting sclerosed. What is sclerosis? The glomeruli are undergoing fibrosis. The glomerular capillary tuft is undergoing fibrosis. Okay, focal means less than 50%. Less than 50% of glomeruli, and in each glomerular segment there is less than 50% of the glomeruli, and there is segmental sclerosis or fibrosis. So what is focal segmental glomerulosclerosis? Focal segmental glomerulosclerosis means the glomeruli are showing fibrosis, less than 50% of glomeruli are showing fibrosis, and in each glomerulus only a segment of the glomerular capillary tuft is fibrosed. Only a segment of the glomerular capillary tuft is fibrosed. The other capillaries are intact. They are not showing fibrosis. So that is focal segmental glomerulosclerosis. Okay, when I use the term membranous glomerulonephritis or membranous nephropathy, what do I mean? When I use the term membranous, it means that in this glomerulonephritis, in this type of glomerulonephritis, the basement membrane of the capillaries is thickened. So that tells you basement membranes of capillaries is thickened. Basement membrane of capillaries is thickened. Then when I use the term acute proliferative glomerulonephritis, when I use the term acute proliferative glomerulonephritis, now the term proliferative will tell you that in this glomerulonephritis, the glomerulus is hypercellular. So you are having a hypercellular glomeruli. So there are hypercellular glomeruli. Okay, then when I use the term membranoproliferative glomerulonephritis, when I use the term membranoproliferative glomerulonephritis, what do I mean? When I use the term membranous plus proliferative, so I imply to tell you that in this glomerulonephritis, number one, glomerular basement membrane is thickened as in membranous. Capillary glomerular basement membrane of glomerular GBM is thickened, glomerular basement membrane is thickened, and second, the glomeruli are hypercellular also. Hypercellular glomeruli are also seen. So this is what I mean by these terms. Okay, now last I drew a schematic diagram. Differentiate between focal and segmental. Okay, now Asad, focal, I explained it to you. See, once again, focal and diffuse, global and focal and diffuse, global and segmental. What is focal and diffuse mean? Focal and diffuse means look at all the 1.5 million glomeruli in the kidney. Focal disease means it's involving less than 50% of the glomeruli. Diffuse disease means out of all 1.5 million glomeruli, more than 50% glomeruli are involved. Okay, so focal and segmental refer to all the glomeruli. अगर बीमारी 50% glomeruli को involve कर रही है तो उसको फोकल कहते हैं. 50% से कम ग्लोमेरुलाई को इन्वॉल्व कर रही है तो उसको फोकल कहते हैं. और अगर बीमारी 50% से ज्यादा किडनी के ग्लोमेरुलाई को इन्वॉल्व कर रही है तो उसको डिफ्यूज कहते हैं. अच्छा, फिर सेगमेंटल और ग्लोबल का क्या मतलब है? पहले तुमने क्या देखे? Focal or diffuse में you looked at all the glomeruli in the kidney. In global and segmental, look at just one glomerulus. If the disease is involving the entire glomerular capillary tuft, that's a global disease. If the disease is involving only a part of the glomerular capillary tuft, the other capillaries in the same glomerulus are spared, that is called as segmental disease. It's involving only a segment of the glomerular capillary tuft. So now, focal segmental glomerulosclerosis means, number one, the disease is, sclerosis means fibrosis. So the glomeruli are showing fibrosis. How many? Less than 50% of the glomeruli are showing fibrosis, and this fibrosis is involving in each glomerulus, it is involving only a part of the glomerular capillary tuft. It is not involving the entire glomerular capillary tuft. Okay. So Asad, I hope the difference between the two is clear to you now. All the others, Rinzan, Muskan, Ujjwal, Preeti, Neha, Parvinder, all of you and whoever is there, these are very basic terms which you have to understand. Once you know the entire concept, if you understand this concept, glomerulonephritis, which is a tough topic, will become very easy for you. Okay. So this is about this. Okay. Now I drew the filtration membrane of the kidney. This was something like this. What was this? This was basement membrane of capillaries. So once again, I am drawing the same figure. These are the endothelial cells. So these are the endothelial cells of the capillaries. Cells of capillaries. And this is visceral epithelial cells. These are visceral epithelial cells. Okay, these are visceral epithelial cells. Then I told you, यहाँ पर क्या है, बाहर क्या है? These are mesangial cells. Mesangial cells. Okay, so these are mesangial cells. Okay, now you know I have already told you in the previous class also. What is the, whenever you get a kidney biopsy? Okay, now let us come to whenever we get a kidney biopsy. Okay, kidney biopsy. For a patient with glomerulonephritis, whenever you get a kidney biopsy for a patient with glomerulonephritis, we divide that kidney biopsy in, we will always say, you have a patient of glomerulonephritis, you want to know which glomerulonephritis this is. You will ask the medical specialist to do a kidney biopsy. Okay, you will ask the medical specialist to do a kidney biopsy. He will do a kidney biopsy. अच्छा, फिर तुम उसको क्या बोलोगे? तुम उसको बोलोगे कि किडनी बायोप्सी में हमें 3 कोर्स निकाल के दो, 3 टुकड़े निकाल के दो. अगर आपको ग्लोमेरुलोनेफ्राइटिस का डायग्नोसिस चाहिए कि कौन सी ग्लोमेरुलोनेफ्राइटिस है, अगर आप चाहते हो कि हम आपको डायग्नोसिस बनाकर दें, तो आप हमें किडनी बायोप्सी के 3 कोर्स भेजो. 3 कोर्स मींस किडनी बायोप्सी के 3 टुकड़े भेजो. सेंड अस 3 कोर्स. Okay, now and how do you send them? Tell them to send you 3 cores. First core, 1 core will come in formalin, 10% formalin. So first core, 1 core, 1 core को किस में भेजो? 1 core you send in 10% formalin. अच्छा, इसको क्या करेंगे? 1% for 10% formalin में आएगी. Formalin, you know, is a fixative. It will come in 10% formalin. We will receive it in pathology laboratory. We will process it. We will cut sections. We will stain it with HNE. We will stain it with HNE. What is HNE? Hematoxylin and eosin stain. You've all seen slides in pathology. They had pink and blue color. That is hematoxylin and eosin. So you stain it with HNE and see under the microscope and you diagnose it. You make a diagnosis. But just staining with HNE is not sufficient. Second, we will also stain it with PAS and silver stains. Silver stains. We will also stain it with PAS and silver stain. अच्छा, PAS और silver stain क्या क्यों करते हैं? क्योंकि very important is this basement membrane. This structure, this basement membrane is very important. And by HNE staining, you can see the endothelial cells of the capillaries. You can see the visceral epithelial cells, but you cannot visualize the basement membrane of the capillaries. So HNE staining पर जो हम रूटीन HNE staining करते हैं, उससे हम कैपिलरी की बेसमेंट मेम्ब्रेन नहीं देख सकते. HNE में हमें क्या दिखता है? HNE में हमें endothelial cells of capillaries दिख जाते हैं, visceral epithelial cells दिख जाते हैं, but you cannot see the basement membrane of the kidney. So PAS and silver stains are the 2 special stains that are done to see the basement membrane. So they are the stains for the basement membrane. So now first core, you have told the clinician to send the first core in 10% formalin. 10% फॉर्मलिन में कोर आ गई, आप उसको HNE से देखोगे, पास और सिल्वर स्टेन से देखोगे. HNE से आप विसरल एपिथेलियल सेल्स देखोगे और एंडोथेलियल सेल्स ऑफ कैपिलरीज देखोगे और पास और सिल्वर स्टेन से आप बेसमेंट मेम्ब्रेन देखोगे. सेकेंड, नाउ व्हाट डू यू सी? सेकेंड core you tell them to put in normal saline. You tell them to put in normal saline and send it to you, and this we will see we will examine, we will put up immunofluorescence staining and we will see it under immunofluorescence microscope. So we will perform immunofluorescence on this. So I will tell you the reason why we perform immunofluorescence also. And third core of kidney biopsy, you will put it in 2.5% glutaraldehyde. And now this will go for electron microscopic examination. So kidney biopsy को हमें किडनी बायोप्सी के 3 कोर्स मांगने हैं, और किसी भी किडनी बायोप्सी में अगर ग्लोमेरुलोनेफ्राइटिस का डायग्नोसिस बनाना है, जो कि हम आगे पढ़ेंगे, आपको 3 कोर मांगने हैं. पहला कोर फॉर्मलिन में आएगा, जो आएगा उसको आप रूटीन प्रोसेसिंग करेंगे, उसको H&E स्टेनिंग से देखेंगे. पास और सिल्वर स्टेन, हम स्पेशल स्टेन्स बोलते हैं इनको, वो हम लगाएंगे ताकि हम बेसमेंट मेम्ब्रेन को विजुअलाइज कर सकें, so that we can see the basement membrane, because there are diseases that will cause the thickening in membranous glomerulonephropathy. There is thickening of the basement membrane. So when you want to see a thickened basement membrane, you will see it by pus and silver stain. Achha, second core, you will ask the clinician to send it in normal saline and you will do an immunofluorescence examination on that. And third core, you will see on 10%, you will ask them to put it in 2.5% glutaraldehyde and you will examine it by electron microscopy. Okay, now second question, why do we do immunofluorescence? Why do we do an electron microscopy? Okay, now come back to this filtration membrane structure again. Achha, agar we will read the glomerulonephritis just now. You know, in most of the glomerulonephritis are immune mediated. They are immune mediated. Immune mediated means in most of the glomerulonephritis, immune complexes are deposited. Okay. Now, where are the immune complexes deposited? 1, 2. What are the immune complexes composed of? Okay. Now, in most of the glomerulonephritis that we will see, immune complexes are deposited. And where are these immune complexes deposited? Immune complexes के पास 4 जगह हैं किडनी में deposit होने के लिए. And these immune complexes are damaging the kidney. They are causing glomerulonephritis. So now, where do the immune complexes deposit? Number 1, these are the endothelial cells. Immune complexes can deposit here. This is called subendothelial location, subendothelial deposits. So immune complexes deposit below the endothelial cells. So this is the between the basement membrane and the endothelial cells. So they deposit somewhere here. What is this location called? This is called subendothelial location. Second, in some diseases, immune complexes deposit right in the center of the basement membrane or right inside the basement membrane. These immune complexes are called intramembranous. Acha, तीसरा, in some kidney diseases, immune complexes deposit here, somewhere here, that is below the visceral epithelial cells. This location is called subepithelial location. And fourth, these some immune complexes deposit here. What is this? This is the mesengium of the kidney. Mesengium. So these are mesangial deposits. So between the capillaries you have the mesangial cells. Mesangial cells produce the mesangial matrix. So they deposit in the mesengium. So immune complexes, most of the glomerulonephritis are immune mediated. Immune complexes damage the filtration membrane of the kidney, cause glomerulonephritis. Where all can the immune complexes be deposited? The location is number 1. In some diseases, I will say they are subendothelial. In some diseases, they are intramembranous. In some diseases, they are subepithelial. And in some diseases, they are mesangial. Immune complexes are mesangial. So, immune complexes deposition is subendothelial, intramembranous, subepithelial and mesangial deposits. These are 4 locations for deposits. Okay, now, you know, these immune complexes are very, very tiny. You can't see them by, these immune complexes are very, very tiny. You cannot see them by H&E staining. H&E पास और सिल्वर स्टेन करके फॉर्मलिन से प्रोसेस करके हम इसको लाइट माइक्रोस्कोप, नॉर्मल लाइट माइक्रोस्कोप से देख रहे हैं. So when you put 1 core in 10% formalin and you process it, see it by He, pass and silver stains, You are seeing it by the routine light microscope which you all know, जो आप सब ने देखी हुई है. So उससे क्या दिखेंगे हमें? विसरल एपिथेलियल सेल्स तो दिख जाएंगे, एंडोथेलियल सेल्स भी दिख जाएंगे. बेसमेंट मेम्ब्रेन को देखने के लिए हम पास और सिल्वर स्टेन करेंगे, बट ये सब हम लाइट माइक्रोस्कोपी से देख रहे हैं. Now immune complexes which are subendothelial, intramembranous, subepithelial or mesangial, they are very very tiny. You cannot see them by light microscopy. So how will you see them? Now the third core that has come in 2% glutaraldehyde, and you do an immunofluorescence. Now by immunofluorescence you do an electron microscopy. So now by electron microscopy you can visualize these immune complexes. So immune complexes cannot be seen by light microscopy. So that is why we ask the clinician to submit one core in 2% glutaraldehyde for electron microscopic examination. So under the electron microscope you will be able to tell whether the deposits are subendothelial, whether they are intramembranous, whether they are subepithelial or they are mesangial. These are the only 4 locations. There is no other location. And last, third, I told you we tell them to send in normal saline for immunofluorescence examination. So by immunofluorescence, now what do you want to see? Now we have already seen these are the immune complexes. अब तीसरा सवाल है, इस immune complex में क्या है? कौन सी एंटीबॉडी है? IgG है, IgM है, IgA है, या तीनों है? दूसरा, इस immune complex में कौन से complement components हैं? My class, water दे दो please. कौन से which are the complement components? Is it C1? You know complement components are C1, C2, C4, C3. These are the complement components. So you want to know what do these immune complexes, which complement components do they contain? Do they contain the complement components of the classical pathway or the alternate pathway? So C1, C2, C4, if you see, they indicate that the classical complement pathway is getting activated. And if you see, bring the bottle also. If you see C3, only C3, no C1, C2, C4. That means alternate complement pathways are getting activated. So now immunofluorescence examination will tell you which antibody and which complement components are there in immune complexes. So what do these immune complexes contain? Which complement components do these immune complexes contain? Do they have IgG antibody? Do they have IgA antibody? Do they have IgM antibody? These are the options. It will be either IgG, IgA, IgM or a combination. Or do they have C1, C2, C4, which will indicate classical, or do they have only C3, which will indicate only C3 if it is present? If C1, C2, C4 along with C3 are present, that means it's a classical pathway. Or if only C3, C1, C2, C4 नहीं है, that means alternate complement pathway activate हुआ है. तो अब हमने ये सब देखने के लिए immunofluorescence करते हैं. So immunofluorescence से we can identify which antibody is found in these components. So once again, to summarize, this part is very important. Number one, you should know the structure of the filtration membrane of the kidney. Filtration membrane of the kidney has innermost layer is the endothelial cells of the capillaries, then the basement membrane of the capillaries, and then the visceral epithelial cells. Then glomerulonephritis is the inflammation of the glomerulus. In glomerulonephritis, the filtration membrane is damaged because of deposition of immune complexes. These immune complexes have 4 possible locations. These immune complexes can be subendothelial in location, that is between the endothelial cells of capillaries and the basement membrane. Second, they can lie within the basement membrane. Third, they can be subepithelial, that is between the visceral epithelial cells and the basement membrane. Fourth, they can be mesangial in location So whenever you get a kidney biopsy, you ask the clinician to submit 3 cores. First core will come in 10% formalin. You will process it routinely, do an H&E staining and look for the hypercellularity of the glomerulus, do a PAS and silver stain, and look for the thickening of the basement membrane, because PAS and silver stains can help you to visualize the basement membrane. By H&E staining, You cannot visualize the basement membrane. You can see endothelial cells, you can see the visceral epithelial cells, but not the basement membrane. Then tell them to submit the second core in the normal saline, and you will do an immunofluorescence examination. By immunofluorescence examination, you will be able to find out which antibodies and which complement components are found inside these deposits. And third core, you ask them to submit into 2.5% glutaraldehyde so that you can do and electron microscopy, and by electron microscopy you will find out the location of these immune complexes. So this is the introduction part which you have to know. Acha, one more term, I will be using the term primary glomerular disease. Primary glomerular disease. You may come across the term primary glomerular diseases. What are primary glomerular diseases? A primary glomerular disease is a disease that involves the glomeruli, or primarily the glomeruli. So kidney disease, so it's a kidney disease involving the glomeruli, impacting only the glomeruli. So kidney disease impacting only the, so better word is impacting only the glomeruli. And secondary glomerular disease, what is the secondary glomerular disease? This is now primary means primary kidney disease जिसमें कि glomerular involvement हो रही है. और secondary glomerular disease क्या है? A systemic disease or disease of any organ, other organ which is involving the glomeruli as well. So a systemic disease that impacts the glomeruli as well. That involves the, or that impacts the glomeruli as well. So it impacts the glomeruli as well. Example, SLE, diabetes mellitus. You know, SLE is a multi-system disease which has an impact on the glomeruli also. Whereas minimal change disease, minimal change disease is a primary glomerular disease. It is not a systemic disease. So this is what we have to do, learn about these. Okay, now everyone, please tell me on the live chat, have you understood this much part? I know this is simple, many of you may be knowing, but this is the basic part which you all have to know. So please tell me, have you all understood? Rinzin, Muskan, Asad, Ujwal, Parvinder, Neha, have you all understood? Today Raghavendra is not there. Have you all understood this much part? Have you all understood this much? This part, understanding this part is very, very important. Please write on the chat. Please write on the chat. All of you, I want your response. Please write on the chat. If you want me to repeat anything, I will repeat it for you. But please understand. So Parvinder said yes. What about others? So whenever you get a kidney biopsy, ask for 3 cores. One core should come in 10% formalin. Second core should come in normal saline. First core comes in 10% formalin. You do a light microscopy. In light microscopy, you will do H&E staining, and to look at the basement membrane, you will see you will do a pass and silver stain, because pass and silver stains will highlight the basement membrane. Second core will come in normal saline. You will do an immunofluorescence examination. Third core will come in 2.5%, or we also say 2 to 4% glutaraldehyde, and you will do an electron microscopic examination on that. And by electron microscopy, you will get the information. What information do you get? The information that you get is where is the immune complex hiding in the filtration membrane. Okay, now next. Okay, so most of you have understood. Good. Now let's come to clinical manifestations of kidney disease. अब किडनी की बीमारी है, किडनी की बीमारी glomerulonephritis भी हो सकती है, किडनी की बीमारी tubular, so inflammation of the glomerulus is glomerulonephritis, inflammation of the tubules and the interstitium is tubulointerstitial nephritis, then inflammation of the pelvis is pyelonephritis, pelvic glacial system is pyelonephritis, P-Y-E-L-O, pyelonephritis. Then, so all these are kidney diseases. And then you can have tumors in the kidney also. So all these are kidney diseases. So now, if a person has a kidney disease, what are the common clinical features that the person presents with? So kidney disease के manifestations, clinical manifestations. पहला clinical manifestation है azotemia. What are the clinical? कोई भी किडनी डिजीज हो, कोई भी किडनी में बीमारी हो, उसके क्लिनिकल मैनिफेस्टेशंस क्या होंगे? पहला क्लिनिकल मैनिफेस्टेशन है एजोटीमिया. What is एजोटीमिया? एजोटीमिया is it's a biochemical abnormality. What is it? It's just a biochemical abnormality. Biochemical abnormality. And what is azotemia? Azotemia means increased blood urea nitrogen and increased creatinine, serum creatinine levels. So if serum creatinine and BUN levels are elevated and everything else is okay, you say there is azotemia, and it's just a biochemical abnormality. Okay, now this is first, that is azotemia. Okay, second is patient with renal disease can present with nephritic syndrome. Nephritic syndrome. Nephritic syndrome. Third, so we will be discussing all this. They can present with nephrotic syndrome. Nephrotic syndrome. Okay, nephrotic syndrome. Okay. Fourth, they can present with nephrotic syndrome. So nephritic syndrome, nephrotic syndrome. Then they can another manifestation is acute kidney injury. Patient can present with acute kidney injury. That's a clinical manifestation of kidney disease. So we will be discussing all that. Fifth is chronic kidney injury. Kidney injury. So they can present with chronic kidney injury. So they can present with acute kidney injury. They can present with chronic kidney injury. Sixth, obstruction of the urinary tract. Patient can come with obstruction of urinary tract. They can also come with obstruction of the urinary tract, or you can have renal tumors. Renal tumors can have their own manifestations like a flank mass, etc. Like a flank mass, etc. Okay, so these are the manifestations. So this is just I am giving you an outline. इसमें अभी हम पढ़ेंगे, सब क्लियर हो जाएगा. अच्छा, क्लिनिकल मैनिफेस्टेशंस ऑफ किडनी डिजीज है. पहला है शब्द है एजोटीमिया. What is azotemia? Azotemia is a biochemical abnormality. Just a biochemical abnormality. What is azotemia? When जब यूरिया बढ़ जाए, क्रिएटिनिन बढ़ जाए, उसको एजोटीमिया कहते हैं. इंक्रीज सीरम यूरिया एंड क्रिएटिनिन लेवल, दिस इज अ बायोकेमिकल एबनॉर्मलिटी. यूरिया एंड क्रिएटिनिन लेवल्स आर एलिवेटेड, दैट इज कॉल्ड एजोटीमिया. अच्छा, दिस इज जस्ट अ बायोकेमिकल एजोटीमिया. लेकिन अगर एजोटीमिया के साथ साथ if you get clinical signs and symptoms also, that is called uremia. So azotemia is a biochemical abnormality along with clinical signs and symptoms. So if you have clinical signs and symptoms like involvement of the GI tract and other organs, that is called as uremia. So what is uremia? Uremia is azotemia plus clinical signs and symptoms. So azotemia is a biochemical abnormality. BUN and creatinine levels are, whenever BUN and creatinine levels are elevated but patient is absolutely asymptomatic, there are no clinical signs and symptoms, we say patient has azotemia. When azotemia is accompanied by clinical signs and symptoms of involvement of many organs, that is called as uremia. So now the kidney disease ki manifestation mein, these are the manifestations of the kidney disease. Okay, so these are the manifestations. Now let us come to glomerulonephritis. So now coming to glomerulonephritis. Okay, glomerulonephritis is inflammation of the glomerulus. Inflammation of the glomerulus is called glomerulonephritis. Okay, now if a patient has glomerulonephritis, what will the patient present with? Patient can present with, so most of the glomerulonephritis, patient can present with nephritic syndrome. They can present with nephrotic syndrome, or a combination of two, or nephrotic syndrome, or there will be co-presentation with both nephritic, features of nephritic and nephrotic syndrome. So or there will be co-presentation with features of both nephrotic and nephritic syndrome. So there will be nephrotic plus nephritic features, nephritic syndrome features. So what is glomerulonephritis? Inflammation of the glomerulus is glomerulonephritis. Glomerulonephritis का मरीज कैसे प्रेजेंट करेगा? नेफ्रिटिक सिंड्रोम के साथ प्रेजेंट करेगा, या नेफ्रोटिक सिंड्रोम के साथ प्रेजेंट करेगा, या ऐसी पिक्चर होगी जो नेफ्रिटिक नेफ्रोटिक दोनों का कॉम्बिनेशन होगी. So that is glomerulonephritis. Okay, now let us see which are the glomerulonephritis. Let us see the names of glomerulonephritis that present with nephritic syndrome, those that present with nephrotic syndrome. So let us first see nephritic syndrome. नेफ्रिटिक सिंड्रोम. अच्छा, पहले तो देखते हैं नेफ्रिटिक सिंड्रोम होता क्या है. सो नेफ्रिटिक सिंड्रोम में क्या है? देयर इज इन्फ्लेमेटरी प्रोसेस. सो इट इज द इन्फ्लेमेशन ऑफ द ग्लोमेरुलस. नेफ्रिटिक सिंड्रोम इज ड्यू टू inflammation of glomerulus. So why does it occur? Because the glomerulus is inflamed. That damages so inflammation of the glomerulus that damages the filtration membrane. You know the filtration membrane or the mesenterium. So that damages the filtration membrane. So you know filtration membrane is made up of the endothelial cells, basement membrane of the capillaries and visceral epithelial cells. That damages the filtration membrane or the mesenterium of the glomerulus. So these are any of these get damaged. Okay, अब nephritic syndrome के features क्या क्या हैं? What are the features of nephritic syndrome? So nephritic syndrome. So in nephritic syndrome, filtration membrane or very specifically GBM is damaged. Glomerular basement membrane is damaged. So in nephritic syndrome, features are number 1, hematuria. What is hematuria? Passage of RBCs in the urine. Second, so hematuria is passage of RBCs, and very important feature, whenever you will see something called as dysmorphic RBCs in the urine, RBCs and RBC casts in the urine. Casts in the urine. You will see dysmorphic RBCs or RBC casts in the urine. अच्छा, dysmorphic RBCs क्या होते हैं? Dysmorphic RBCs means dysmorphic. That means उनकी shape बिगड़ी हुई है. So they appear crenated. They are not normal round RBCs. They appear something like this. These are dysmorphic RBCs. And dysmorphic RBCs, if they appear, they always suggest that the hematuria is glomerular in origin. अच्छा, casts are always formed in the tubules of the kidney. So जब भी cast word आएगा, remember casts are always formed in the tubules of the kidney. So if you see dysmorphic RBCs always indicate glomerulonephritis. So now features of nephritic syndrome are number 1, hematuria. So patient of nephritic syndrome has hematuria. There are dysmorphic RBCs and even RBC casts. Second, they have azotemia. Azotemia क्या होता है? Increase bun, increase creatinine. Increase creatinine. Third is oliguria. Oliguria, again you know what is oliguria? Passage of less amount of urine. So when less amount of urine is passed, that is called as oliguria. So oliguria is passage of less amount of urine by the kidney is called as oliguria. So third feature is oliguria, where less amount of urine is passed by the kidney. So you have hematuria, azotemia, oliguria. Fourth feature is hypertension. So fourth feature is hypertension. This is due to salt retention. This is due to salt retention. And fifth feature is proteinuria. अच्छा, अब मैं यहाँ पे लिखूंगी proteinuria है. प्रोटीन्यूरिया जो है वो कम भी हो सकता है, ज्यादा भी हो सकता है. प्रोटीन्यूरिया में भी we will after this I will talk about nephrotic syndrome. In nephrotic syndrome, lots and lots of proteins are passed in the urine. By lots and lots, how much do I mean? More than 3.5 grams of proteins are passed every day in the urine. So proteinuria usually होता है, but proteinuria is usually I'm using the word usually not of nephrotic range. So nephrotic syndrome जितना नहीं होता है. So what are the features of nephritic syndrome? What are the features of nephritic syndrome? Of urine. So in nephritic syndrome we have hematuria. What is hematuria? Dysmorphic RBCs and RBC. There is hematuria. Second, there is azotemia. Third, there is oliguria. Fourth, there is hypertension. Fifth, there is proteinuria. So hematuria. What is azotemia? Raised blood urea and creatinine levels. Oliguria, hypertension due to salt retention, and proteinuria, but proteinuria will be less than what is seen in nephrotic syndrome. So these are the 5 features of nephritic syndrome. Okay, now next, which are the glomerulonephritis that present with nephritic syndrome? So glomerulonephritis that present with nephritic syndrome are number 1, Number 1, acute post-streptococcal. Acute post-streptococcal. Just a moment. I'm sorry for the disturbance. Okay, now glomerulonephritis. Which are the glomerulonephritis that cause nephritic syndrome? So number 1, acute post-streptococcal glomerulonephritis. Acute post-streptococcal glomerulonephritis. So these people present with nephritic syndrome. So please learn up all the features of nephritic syndrome. So you already know all the features of nephritic syndrome. Okay. Second glomerulonephritis that presents with nephritic syndrome is rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis or RPGN. Third is IgA nephropathy. Fourth is diffuse proliferative glomerulonephritis. Fifth is membranoproliferative glomerulonephritis. And sixth is Alport syndrome. So now let us see the glomerulonephritis that present with nephritic syndrome. So first, nephritic syndrome के features क्या हैं? Hematuria, RBCs will be passed in the urine, RBC casts may be there in the urine, dysmorphic RBCs will be there. Dysmorphic RBCs, तभी RBC dysmorphic होता है, उसका हुलिया बिगड़ता है, उसकी शेप बिगड़ती है, वो क्रिनेटेड लगता है जब वो ग्लोमेरुलोनेफ्राइटिस की वजह से बना हो. अच्छा, second है azotemia. Azotemia means now this patient with nephritic syndrome will have a high blood urea and creatinine level. Third, oliguria, passage of less than 400 ml of urine in 24 hours. Fourth, hypertension. Fifth, proteinuria. Proteinuria होता है लेकिन proteinuria nephrotic syndrome जितना नहीं होता. अच्छा, अब कौन कौन सी ग्लोमेरुलोनेफ्राइटिस हैं? 6 कंडीशंस हैं, 6 ग्लोमेरुलोनेफ्राइटिस हैं जो नेफ्रिटिक सिंड्रोम, जिसका मरीज नेफ्रिटिक सिंड्रोम के साथ प्रेजेंट करता है. वो है एक्यूट पोस्ट स्ट्रेप्टोकॉकल, rapidly progressive glomerulonephritis, IgA nephropathy, diffuse proliferative glomerulonephritis, membranoproliferative and Alport syndrome. Okay, now I will be talking about each of them in detail. So I will be covering each of them in detail. Okay, now let us see if I have some images. Okay, till now everything is clear to all of you? Till now everything is clear? Okay, I will be telling you about this picture also. Okay, we'll come to this picture later. Okay, first let us start with, okay, I hope everything is clear. So first let us come to first one, that is first acute proliferative glomerulonephritis. Acute proliferative. First let us see acute proliferative glomerulonephritis, or also called as acute post-streptococcal. Another name is acute. So it is acute post-streptococcal glomerulonephritis or acute proliferative or acute post-streptococcal glomerulonephritis. Achha, ab as the name suggests, post-streptococcal. So acute post-streptococcal glomerulonephritis most commonly seen in children. children. So it's seen in children. It can occur in adults also, and usually it occurs 2 to 4 weeks following. Occurs 2 to 4 weeks following infection with group A beta hemolytic streptococcus. Hemolytic streptococcus. सो ये एक्यूट पोस्ट स्ट्रेप्टोकोकल क्या होती है, बच्चों में होती है और स्ट्रेप्टोकोकल इन्फेक्शन के बाद होती है. कौन सा स्ट्रेप्टोकोकल इन्फेक्शन? ग्रुप ए बीटा हेमोलिटिक स्ट्रेप्टोकोकल इन्फेक्शन. एंड ये इन्फेक्शन कहाँ का होता है? इन्फेक्शन ऑफ फेरिंग्स एंड स्किन. सो इधर दे विल हैव sore throat, it follows sore throat, or it follows the group A beta hemolytic streptococcal infection of pharynx. Pharynx means sore throat or skin. It follows that, pharyngeal or sore throat. Sore throat follows sore throat by group A beta hemolytic streptococcal or skin infection. And it is a type 3 hypersensitivity reaction. You know, in type 3 hypersensitivity reaction kya tha? It's immune complex disease. So now in response to this group A beta hemolytic streptococcus, antibodies are produced. Antigen and antibody combine together to form an immune complex, and now this immune complex goes and deposits in the glomeruli and damages the glomeruli. Acha, now let us see light microscopy. Now we will see all the features. So this follows group A beta, it's a type 3 reaction, follows group A beta hemolytic streptococcal infection. Clinical features we already know. The child will present with nephritic syndrome. Clinical feature kya hai? The child will present with nephritic syndrome, and he will present with nephritic syndrome. Okay, now you do a kidney biopsy. So now let us see lab tests. You do a lab test. Okay, in lab test, number one, if you look at urine examination, urine will be cola colored. They will have cola colored urine. Cola colored colored या cocoa colored urine or brown colored urine is because of hematuria. So there is cola colored urine. Acha, second, so there is cola colored urine. So they have nephritic syndrome. They will have features of nephritic syndrome. They may also have, because of proteinuria, they can have periorbital edema also. Periorbital edema, because periorbital edema, this is characteristic of kidney, and they will have hypertension as well. All the features of nephritic syndrome will be there. Okay, so urine is cola colored. 1, 2, if you do a serology, if you do serology, this is ASLO titers are positive, anti-streptolysin O. So ASLO, increase ASLO titers. Anti-streptolysin O titers are elevated. So they are elevated, anti-ASLO titers are elevated. Now do a kidney biopsy. You want to make a diagnosis, you do a kidney biopsy. Okay, now if you do a kidney biopsy, number one, light microscopy. Number one, light microscopy. Now what do you do by light microscopy? Now the term is acute post-streptococcal or acute proliferative glomerulonephritis. So by light microscopy, when you see the glomeruli are enlarged, they are big, they will appear enlarged and hypercellular. So ये कैसे दिखा enlarged and hypercellular? We have done H&E staining. H&E staining से जब हम light microscopy में glomeruli देखेंगे, glomeruli are enlarged and hypercellular. अच्छा, अब ये glomeruli इतना hypercellular क्यों है? क्यों? Why is the glomerulus big and hypercellular? Because there are more than normal people in the glomeruli. There are more than normal people sitting in the glomeruli. So who are these people? So it is acute proliferative. So somebody is multiplying in the glomeruli. Who is multiplying? The mesangial cells are increasing in number. The endothelial cells lining the capillaries are increasing in number. And third, even the inflammatory cells, monocytes and neutrophils are coming from outside and they are filling the glomerulus. All these three together combined, they are making the glomerulus hypercellular. So the glomeruli are enlarged and hypercellular due to proliferation of endothelial cells. So they are proliferating. Mesangial cells and entry of and infiltration by monocytes and neutrophils. Even neutros come. All of them come and they make the glomerulus look very cellular by this microscope. So this is acute proliferative glomerulonephritis. However, basement membrane is not thickened. Okay, so this is what you see by light microscopy. Okay, now let us see by electron microscopy. Do an electron microscopy. Now what do you see by electron microscopy? So now this was what I drew. These are the endothelial cells and this is the visceral epithelial cells. So now by electron microscopy you see the deposits. You see the deposits. Now where are the deposits? The deposits are deposits are subepithelial in location. They are here. They are like this. The deposits are somewhere here. So where are these deposits? And they are big deposits. So by electron microscopy, what do we have? The deposits, they are subepithelial. They may be subendothelial also at times. So sometimes they may be here also, but mostly they are subepithelial, and we call them lumpy bumpy deposits. Lumpy bumpy deposits. Lumpy bumpy deposits. So subepithelial hai, usually subepithelial hai, rarely subendothelial. So mainly subepithelial, lumpy bumpy, they are big fat deposits. Inko subepithelial humps bhi kehte hain. They are also called subepithelial humps. Also called subepithelial humps or lumpy bumpy deposits. Okay, now third immunofluorescence करते हैं. अब हम झांक के देखना चाहते हैं इन deposits में है क्या. So now do an immunofluorescence. Immunofluorescence में पहला दो चीजें देखते हैं हम. Immunofluorescence में हम देखेंगे which is the antibody, which is the complement in them, in these deposits. Second, by immunofluorescence you also see whether these deposits are continuous or they are discrete granular deposits. So by immunofluorescence these are granular deposits. So there is one granule here, one granule here. They are granular deposits. They are discrete deposits. They are separate. They are not continuous deposits. So they are granular deposits, and they contain IgG also. They contain IgM also, and they contain C3 is also deposited in these deposits. So C3 is also deposited. So immunofluorescence now gives a starry sky appearance. Starry sky appearance by immunofluorescence. And what do the deposits contain? They contain IgG antibody, they contain IgM, and they contain C3 complement component. So C3 is also there. So C3 is also there. So this is what we see, and presentation also we have seen. Okay, now last point. Usually most of the 95% children recover spontaneously, recover on their own spontaneously. Okay, so 95% children recover spontaneously. Okay, now periorbital edema. Acha, ab hum ek baar phir se, let us come back to this. Now Muskan has asked me why periorbital edema. Okay, now let us see kidney disease के features क्या क्या हैं? Hematuria. Nephritic syndrome के features क्या हैं? Hematuria, azotemia, oliguria, hypertension and proteinuria. Acha, now whenever proteins are lost in the urine, if proteins are lost in the urine, most common protein lost is albumin. So now you know, if albumin is lost in the urine, there is hypoalbuminemia. So albumin in the blood will reduce, and you know albumin is responsible for maintaining the plasma colloid osmotic pressure. So now if albumin is lost in the urine, this will lead to edema. So अगर albumin is lost in the urine, this will lead to edema. अच्छा, edema सबसे commonly कहाँ होगा? Peripheral parts में होगा, पाँव में होगा. The feet will become swollen, and especially in kidney disease, if the edema is because of kidney disease, the first if edema is due to kidney disease, it first appears around the eyes. So first you see periorbital edema, then the feet also get swollen, and you can have generalized edema or anasarca also. So that is proteinuria, because proteins are lost, albumin in the blood is decreasing. Since albumin in the blood is decreasing, plasma colloid osmotic pressure is decreasing. Since plasma colloid osmotic pressure is decreasing, that is causing fluid to go out of the blood vessel into the tissues, leading to edema. And in case of kidney disease, the edema first begins around in the eyeball. So it's a periorbital edema. So this is first entity causing nephritic syndrome is acute post-streptococcal glomerulonephritis, which is seen mainly in children. This follows, it occurs 2 to 4 weeks following infection with group A beta hemolytic streptococcus. The infection is of the skin of pharynx. It's a type 3 reaction. The child presents with nephritic syndrome, all the features of nephritic syndrome, and periorbital edema is also there. Hypertension is a part of nephritic syndrome. Urine is cola colored. ASLO titers are elevated. Kidney biopsy, the glomerulus is hypercellular. Enlarged and hypercellular subepithelial lumpy bumpy deposits are seen by electron microscopy. Immunofluorescence, we have granular deposits composed of IgG, IgM and C3 complement component. So this is acute proliferative glomerulonephritis. Okay, second important glomerulonephritis is rapidly progressive glomerulonephritis. Another name for rapidly progressive glomerulonephritis is, it's also called as crescentic glomerulonephritis. You know, moon can be crescent shaped. This is crescentic. Okay, now RPGN, rapidly progressive glomerulonephritis. So what is RPGN? What is the definition of RPGN, rapidly progressive glomerulonephritis? This is within days to weeks, renal function deteriorates, it falls down. So this is rapid deterioration of renal function. So very quickly the renal function deteriorates in days to weeks. So there is rapid deterioration of renal function in days to weeks. So renal function very rapidly it deteriorates, and this glomerulonephritis carries a poor prognosis. Okay, now it's called crescentic glomerulonephritis. Now, okay, one important point here is a number of glomerulonephritis, a number of conditions. RPGN is like a dustbin. A number of conditions can lead to RPGN. So patients with Goodpasture syndrome can have RPGN. Patients with Wegener's granulomatosis can have RPGN. Patients with other acute post-streptococcal में 95% children acute post-streptococcal resolves spontaneously. In 5% they may have complications. One of the complications is they can go into RPGN. So a number of glomerulonephritis as a complication can go into RPGN. So RPGN is, what is the definition? Rapid deterioration of renal function within days to weeks, and it carries a poor prognosis. Now if you see RPGN, causes of RPGN. So I told you it's like a dustbin. Many glomerulonephritis can cause RPGN. So causes of RPGN can be divided into three broad categories. First is type 1 RPGN. Type 1 RPGN is also called anti-GBM disease. So type 1 RPGN is also called anti-GBM disease. So as the name suggests, it is the glomerular anti-GBM disease. So now type 1 RPGN का example है Goodpasture syndrome. Okay, now you know what is Goodpasture syndrome. Goodpasture syndrome is a type 2 hypersensitivity reaction. It's a type 2 hypersensitivity reaction. In Goodpasture syndrome, antibodies are produced. So in Goodpasture syndrome, antibodies are produced against alpha 3 chain of type 4 collagen. So in Goodpasture syndrome, antibodies are produced against alpha 3 chain of type 4 collagen. So where do you find type 4 collagen? Our basement membrane has type 4 collagen. So now so this is the basement membrane of the kidney. This is the alpha 3 chain of type 4 collagen. In Goodpasture syndrome, antibodies are produced against this alpha 3 chain of type 4 collagen. These antibodies will go and attach, and these antibodies will go and will cause damage to the basement membrane. So these antibodies damage the basement membrane. अच्छा, अब कौन सी basement membrane? Antibodies damage the glomerular basement membrane, GBM, that is glomerular basement membrane, as well as the alveolar basement membrane. So basement membrane of the alveoli as well. And so the patient now presents with nephritic syndrome. So clinical features of Goodpasture is they will have hematuria, suggestive of kidney disease, that is they will have nephritic syndrome with hematuria and other features, and second they will have hemoptysis as well. Hemoptysis, why? Because of lung involvement. So lung involvement will produce hemoptysis as well. lung involvement will produce hemoptysis as well. So this is type 1 RPGN, in which we have anti-GBM antibodies. This is seen in Goodpasture syndrome, which is a type 2 hypersensitivity reaction. In Goodpasture syndrome, antibodies are produced against the alpha 3 chain of type 4 collagen. These antibodies attach to the alpha 3 chain. These antibodies attach to the alpha 3 chain, and these antibodies damage the basement membrane of the kidney. The antigen, it is type 2 reaction because the antigen is fixed inside the basement membrane. If you remember the chapter of immunopathology, type 2 hypersensitivity reaction was when the antigen was fixed. So here the antigen is fixed in the GBM, antibodies travel to the antigen, attach to the antigen and damage the GBM. They damage the kidney basement membrane, producing nephritic syndrome. They damage the lung basement membrane, producing hemoptysis as well. So patient has hemoptysis and this also. Okay. Second cause of RPGN, second category of cause of RPGN, type 2 RPGN. Second is type 2 RPGN. Type 2 RPGN. Type 2 RPGN is called immune complex disease. Immune complex disease. Second, type 2 RPGN is called immune complex disease. So now type 2 RPGN or immune complex disease, now these are the people with acute post-streptococcal. You know, 5% children with acute post-streptococcal glomerulonephritis can go into RPGN. Patients of IgA nephropathy can go into RPGN, or patients with other glomerulonephritis. So in acute post-streptococcal, immune complexes are formed. So or patients with SLE can also go into RPGN. So SLE is also an immune complex disease. So these immune complexes are damaging the kidney and there's rapid deterioration of kidney function. This is type 2 RPGN. And then last is type 3 RPGN. Type 3 RPGN. Type 3 RPGN is also called posse-immune RPGN. Okay, now what is posse-immune? Here you don't have any immune complexes. So what do you have in posse-immune then? In posse-immune RPGN is ANCA associated RPGN. ANCA. Now what do you mean by the term ANCA? ANCA stands for anti-neutrophil cytoplasmic antibodies. So what are ANCAs? ANCAs are anti-neutrophil cytoplasmic antibodies. That means antibodies against the enzymes found in the neutrophils. So if this is a neutrophil, this is the nucleus of the neutrophil. You know, in the neutrophil you have these granules. The neutrophils are are WBCs which have granules. In their granules they have enzymes. So ANCAs are antibodies against the enzymes found in these granules. So you know, inflammation के चैप्टर में पढ़ाया था जो या हेमेटोलॉजी में मैंने बताया था, न्यूट्रोफिल्स के ग्रैन्यूल्स दो तरह के होते हैं, प्राइमरी एंड सेकेंडरी ग्रैन्यूल्स. Primary granules are large coarse granules. So now primary granules have enzymes. When antibodies are produced against these enzymes found in the primary granules, they are called ANCA. So ANCA are anti-neutrophil cytoplasmic antibodies, antibodies against enzymes found in the primary granules of neutrophils. ANCAs are of two types, P-ANCA and C-ANCA. P and C. So anti-neutrophil cytoplasmic antibodies, these are antibodies against enzymes found in the primary granules. So antibodies against enzymes found in primary granules. Okay. Now these antibodies are of two types. Now we'll see the names of the enzymes. These antibodies are of two types, P-ANCA and C-ANCA. Now P-ANCA is an antibody against, enzyme myeloperoxidase or MPO found in the primary granules of the neutrophils. And C-ANCA is an enzyme against PR3. PR3 is proteinase 3, another enzyme found in the primary granules of the neutrophils. So ANCA दो तरह की है, P और C. P-ANCA कौन से एंजाइम के अगेंस्ट है जो प्राइमरी ग्रैन्यूल्स में मिलता है? माइलोपेरोक्सिडेज. C-ANCA कौन से एंजाइम के अगेंस्ट है? PR3 और प्रोटीनेज 3. Both these enzymes are in the primary granules of the neutrophils. So now type 3 RPGN is posse-immune RPGN. That means you don't find immune complexes. You don't find, it's not 1, it's not 2. So in type 3 RPGN, now what do you find? people with type 3 RPGN, they have ANCAs. They have ANCAs. ANCAs go and damage the kidney. So now P ANCAs are found in patients with microscopic polyangiitis. Microscopic polyangiitis. So P ANCAs are found in patients with microscopic polyangiitis. Microscopic polyangiitis is a small vessel. It's an inflammation of small vessels of the kidney. So it's a small vessel vasculitis. Small vessel vasculitis. Small vessel vasculitis. So जिन लोगों को microscopic polyangiitis होता है, microscopic polyangiitis एक वैस्कुलाइटिस है, छोटी वेसल्स का वैस्कुलाइटिस है, जिसमें स्मॉल वेसल्स, हमारी पूरी बॉडी की छोटी वेसल्स इन्फ्लेम हो जाती है, किडनी की भी छोटी वेसल्स इन्फ्लेम हो जाती है, जीबीएम को डैमेज होता है और आरपीजीएन हो सकता है. सो माइक्रोस्कोपिक एंड दीज पीपल हैव पी एंकास इन देयर ब्लड. सेकेंड इज सी एंका. सी एंका इज फाउंड इन पेशेंट्स विद वेगनस ग्रैनुलोमेटोसिस. They are found is found in patients with Wegener's granulomatosis. And so C ANCA, so the Wegener's is also a small vessel, again a small vessel vasculitis. Here microscopic polyangiitis and Wegener's I will be talking about in the chapter of blood vessels. So it's also a small vessel vasculitis. So now these are the three types of RPGN. So once again, number one, again let's come back. RPGN is also called crescentric glomerulonephritis. I'll tell you why. What is RPGN? It is a type of glomerulonephritis which causes rapid deterioration of renal function. How rapid? Within days to weeks the renal function is deteriorates and it carries a poor prognosis. Causes of RPGN: a number of glomerulonephritis can lead to RPGN. Causes of RPGN can be categorized into three categories: type 1 RPGN, type 2 RPGN and type 3. Type 1 RPGN is anti-GBM disease. This is seen in patients with Goodpasture syndrome. Goodpasture syndrome is a type 2 hypersensitivity reaction where antibodies are produced against the alpha-3 chain of type 4 collagen. These antibodies go and attach to the GBM and they cause damage to the GBM. They damage not only the GBM, these antibodies also damage the alveolar basement membrane. So patient has nephritic syndrome due to kidney involvement and patient has hemoptysis due to lung involvement. Then we have type 2 RPGN. This is immune complex disease. These are the people with acute post-streptococcal or other glomerulonephritis or patients with SLE who end up with RPGN. Then we have type 3 RPGN, which is called pauci-immune RPGN. This RPGN is ANCA associated. ANCAs though, what are ANCAs? ANCAs are anti-neutrophil cytoplasmic antibodies. These are the antibodies against the enzymes found in the primary granules of neutrophils. ANCAs are of two types, P and C. P ANCA is against myeloperoxidase. C ANCA is against proteinase 3. P ANCAs are seen in microscopic polyangiitis. C ANCAs are seen in Wegener's granulomatosis. Okay, now let us see light microscopic feature of RPGN. अब light microscopic feature, ये तो causes पढ़े, अब light microscopic features देखेंगे. Light microscopic feature में क्या है? इसको कहते हैं crescentric glomerulonephritis. So crescent moon shaped. So now what do you see? You see crescents in Bowman's space. Bowman's space. So what do you see? You see crescents in the Bowman space. So now if you see, this is the glomerular capillary tuft here. Now this is the, and here you have the okay, I think I have not drawn it properly. Okay, so this is the structure. Please leave this. Look at this. Now these are the glomerular capillaries here. Okay. Now this is the Bowman's space. This is the Bowman space. So now in crescentric glomerulonephritis, what do you see? Crescents are found in this Bowman space. Crescents are found like this. So crescents are found like this in the Bowman space. Now what is this crescent composed of? This crescent is composed of parietal epithelial cells. So crescents are formed due to proliferation of parietal epithelial cells. 2 monocytes come and sit in the crescent, macrophages come and sit, and fibrin also deposits in the crescent. So these 4 components form this crescent, and you know this crescent now compromises the filtration carried out by the glomerular capillary tuft is markedly compromised and there is rapid deterioration of renal function. So you see parietal, what are the crescents? Where are the crescents found? They are found in the Bowman space. They interfere with the filtration of the urine. What are the crescents composed of? They are formed by proliferation of the parietal epithelial cells, monocytes, macrophages, and they are composed of fibrin. So they damage the, they interfere with, they cause rapid deterioration of renal function. Okay, now, so by light microscopy, you will see crescents. Okay, immunofluorescence and electron microscopy. This picture is variable. Variable, why? Because it will depend on which category. If it is type 1 RPGN, deposits are inside the GBM. In Goodpasture syndrome, where will you find the deposits? It will be inside the GBM. If it is type 2 immune complex, deposits can be subepithelial or subendothelial. If it is acute post-streptococcal leading to RPGN, deposits will be subepithelial. If it is some other, the deposits will be as per the disease. And if it is type 3, there are no deposits. Achha, here I have to make a mention of what type of deposits will you find in Goodpastures. Acute post-streptococcal हमने पढ़ लिया, SLE हम आगे पढ़ेंगे. So now if you see in type 1 RPGN, which is Goodpastures, which you see in Goodpasture syndrome, now here where are the deposits? Now in which you see in Goodpasture syndrome, now what do you see? The deposits are inside the GBM. So the deposits you have, so by electron microscopy, deposits are intramembranous. So inside the GBM, so they are intramembranous. And by immunofluorescence, कैसे deposits हैं? They are linear. They are not granular deposits. They are all continuous. If this is the basement membrane, the deposits are something like this. So they are linear. Continuous, and these deposits are composed of IgG and C3. They have IgG and C3 in them. And treatment क्या करते हैं? Treatment of RPGN. In general, treatment of RPGN is emergency plasmapheresis. Pheresis is done to remove these immune complexes or the other components. So this is the second glomerulonephritis, that is RPGN. Okay, I'll be showing you the pictures also. Let me just finish nephritic syndrome. Third is IgA nephropathy. Okay, all of you, till now, is this clear? All the findings? IgA. Please write on the chat if everything is clear till now. Okay, now once again, okay, I'll show you just for a change. I'll show you a picture. अच्छा, हमने पढ़ा था deposits होते हैं. Now, if you look at these, now what are these? These are immune complexes. This is general. In general, for glomerulonephritis, I told you glomerulonephritis is immune mediated. These are immune complexes. This red colored is antigen antibody. These circulating immune complexes, kidney में मैंने ये बताया था कहाँ deposit हो सकते हैं. ये देखो, they can deposit subepithelial. The deposits of immune, I have shown you, I have already explained all this to you. The deposits can be subepithelial. So this is the visceral epithelial cell. This is the basement membrane. These are the endothelial cells. So GBM is drawn here. So deposits can be subepithelial. अभी हमने कौन सी बीमारी देखी थी जिसमें subepithelial deposits थे? Acute post-streptococcal. Second, deposits can be subendothelial. So these are the endothelial cells. They are beneath the endothelial cells. So they are subendothelial. Third, the deposits can be mesangial. Just now I will tell you where the deposits are mesangial. So if you do immunofluorescence, in all these three, if the deposits are subendothelial or they are subepithelial or they are mesangial, they will always, by immunofluorescence, the deposits will always have a granular appearance. If you see here, they are all granules. They are discrete deposits. They will be granular. Second, हमने जो पढ़ा anti-GBM disease पढ़ी अभी, that is Goodpastures. In Goodpastures, antibodies, so the antibodies will come and they will attach to, antibodies are produced against the GBM, against antigen in the GBM. So now here the antibodies are getting deposited inside the GBM. They are interacting with the alpha-3 chain of type 4 collagen. So here now the deposits are linear, they are continuous, and these deposits are, they produce a linear immunofluorescence. So this is what I am trying to tell you, the linear immunofluorescence. So now this is the immunofluorescence picture, this green picture. Now you can see the two patterns. This pattern A, look at A, this is granular deposits. granular deposit which are characteristic of granular, देखो ये सब granular deposits है which are characteristic of immune complex deposition disease. And second, look at picture B. These are linear deposits seen in good pastures or anti-GBM disease. So look at these, they are continuous, they are all uniformly green in color. But here if you see the first picture, they are not uniformly green in color. Okay, so they are not uniformly green in color. Okay, so now we come back, I'll be showing you more pictures as we see more. Okay. So third is IgA nephropathy. Now IgA nephropathy, this is usually seen in young people, young adults. It usually seen in young adults, and characteristic presentation of the patient is recurrent clinical feature. Characteristic clinical feature is recurrent. Patient presents with recurrent gross hematuria. So they present with recurrent gross hematuria. And IgA nephropathy young लोगों में होता है, and it usually follows. They will always give you a history of 2 or 3 days history. They'll always give you a history of follows respiratory or GI tract infection. GI tract infection. अच्छा, यहाँ एक चीज याद रखना है. You know, acute post-streptococcal also can follow pharyngeal sore throat. That follows sore throat or skin infection. But that usually occurs 2 to 4 weeks. Glomerulonephritis or nephritic syndrome in a child occurring 2 to 4 weeks after sore throat or skin infection. IgA nephropathy will occur within 2 to 4 days of upper respiratory or GI tract infection. So आज एक young adult है, उसको डायरिया हुआ, 4 दिन के बाद उसको रिकरेंट हीमेचूरिया होना शुरू हो गया, या रेस्पिरेटरी ट्रैक्ट इन्फेक्शन हुआ, 2 से 4 दिन के बाद उसको हीमेचूरिया होना शुरू हो गया. और क्लासिकल प्रेजेंटेशन क्या है? रिकरेंट ग्रॉस. दे विल कीप हैविंग दीज एपिसोड्स. आज हुआ हीमेचूरिया, फिर कुछ टाइम बाद फिर होगा रिकरेंट ग्रॉस हीमेचूरिया. प्लस दिस इज द मोस्ट कैरेक्टरिस्टिक प्रेजेंटेशन, रिकरेंट ग्रॉस हीमेचूरिया. प्लस दे कैन also present with nephritic syndrome. Okay, so recurrent gross hematuria, nephritic syndrome. Now IgA nephropathy, another name for IgA nephropathy is Berger disease, B-E-R-G-E-R, Berger's disease. Don't confuse it with, this is called Berger's disease, B-E-R-G-E-R. Don't confuse it with thromboangiitis obliterans, which is B-U-E-R-G-E-R, Berger disease. Okay, अच्छा, अब देखें light microscopy. Light microscopy, what do you see? Now here glomerulus, if you look at the glomerulus, in the glomerulus, again glomerulus appears cellular, but now who is proliferating? There is mesangial proliferation. So light microscopy, there is mesangial proliferation. So mesangial cells are proliferating. So mesangial cells की जनता बढ़ जाती है, वो पूरे glomerulus को भर देते हैं. So there is mesangial proliferation. अच्छा, अब immunofluorescence examination देखो, इसका नाम है IgA nephropathy. तो अगर IgA nephropathy है तो अब कौन सी इम्यून कॉम्प्लेक्सेस डिपॉजिट होंगे और कहां डिपॉजिट होंगे? IgA containing immune complexes are deposited in the mesangium. So कहां डिपॉजिट हो रहे हैं? मेसेंजियम में हो रहे हैं. और कौन सी एंटीबॉडी है? IgA. और इम्यूनोफ्लोरेसेंस में वेरी सिंपल, मेसेंजियल immune complexes are seen in the mesangium. So you see, this is IgA nephropathy. So young adults, recurrent gross hematuria, they may have proteinuria, follows concurrently with within 2 to 3 days history of respiratory or GI tract infection will be there, and it's also called as BER-GERS, Berger's disease. So this is third, that is IgA, third cause of nephritic syndrome or just recurrent gross hematuria, that is Berger's disease. Fourth is diffuse proliferative glomerulonephritis. So fourth is diffuse proliferative glomerulonephritis. So now I told you, you know the meaning of the term diffuse, you know the meaning of the term proliferative. Diffuse का मतलब क्या है? More than 50% glomeruli of the kidney are involved, and proliferative का मतलब है the glomerulus is hypercellular. So diffuse proliferative glomerulonephritis की etiology क्या है? ये कौन सी conditions में मिल सकती है? SLE के patients को हो सकती है, या membranoproliferative, अभी हम पढ़ेंगे membranoproliferative glomerulonephritis के patients को बाद में it can convert into diffuse proliferative also. Okay, now clinical features: present with nephritic syndrome. Okay, Okay, now light microscopy, what do we see? Light microscopy, we see wire looping of capillaries. So I will be showing you picture of wire looping of capillaries. So wire looping क्या है? जो capillaries की basement membrane है, capillaries की walls हैं, वो markedly thickened हो जाती हैं. So what is wire looping? Pass positive, you do a pass stain, pass positive thickening of glomerular capillary walls. So the glomerular capillary walls appear markedly thickened. The glomerulus is very cellular, it's proliferative. Many glomeruli, more than 50% glomeruli are involved, and by pass stain, the capillary walls are markedly thickened. They are markedly thickened, and the capillary walls are markedly thickened. Okay. Electron microscopy, what will you see? Now here the deposits are more than one place. You have subendothelial deposits, and sometimes plus even intramembranous deposits. So दोनों मिल सकते हैं. Subendothelial तो मिलते ही हैं, subendothelial के साथ साथ intramembranous भी मिल सकते हैं. और immunofluorescence पे what do these deposits contain? They mainly contain IgG based. IgG with C3 complement components. IgG with C3 complement components. और इसका treatment क्या है? Aggressively treat with steroids. So you have to treat them with steroids aggressively, and remember, it's a common cause of death in SLE patients. So if SLE patients develop this diffuse proliferative, it's a common cause of death. So SLE के मरीजों में अगर diffuse proliferative glomerulonephritis हो जाए, it can lead to death also. So diffuse proliferative glomerulonephritis. So not much in diffuse proliferative. So it can be a complication of membranoproliferative, or it can be seen in SLE. Nephritic syndrome, characteristic feature that you see is wire looping. What is the capillary walls appear thick by pass stain. Electron microscopy, you have subendothelial plus minus subintramembranous deposits. IgG and C3 are found. Okay, fifth is membranoproliferative. Proliferative glomerulonephritis. Okay, membranoproliferative means membrane GBM is thickened plus the glomerulus is hypercellular. So membranoproliferative glomerulonephritis is clinical features. How will they present? They can present with nephritic syndrome. इसको हम nephritic syndrome, glomerulonephritis presenting with nephritic syndrome में पढ़ रहे हैं. So they can present with nephritic syndrome, or sometimes it can be nephritic plus nephrotic picture also. They can present with combination of these two also. अच्छा, etiology, causes इसके क्या है? Causes, it is of two types. अभी हम देखेंगे type 1, type 2. I'll tell you what are these. Type 1 may be idiopathic, or it may be secondary to hepatitis B or hepatitis C infection, secondary to hepatitis B or C infection. And type 2, if you look at type 2 MPGN, membranoproliferative, is associated with C3. These people have C3 nephritic factor in their blood. So type 2 MPGN के मरीजों के blood में C3 nephritic factor होता है. What is C3 nephritic factor? Now, what is this C3 nephritic factor? This C3 nephritic factor is a what you call as, it's a C3 convertase, or C3 nephritic factor is a protein. It stabilizes. It is something that stabilizes C3 convertase. So it stabilizes C3 convertase. You know, C3 convertase participates in the complement. C3 convertase is very important to activate C3. So complement cascade में C3 का activation सबसे important है, और C3 का activation करता है C3 convertase. C3 nephritic factor stabilizes C3 convertase. That is its function. Okay, now coming to type 1 and type 2 features. Okay, now light microscopy. पहले light microscopy पे देखते हैं. हम इसको कहते हैं membranoproliferative glomerulonephritis. So I told you what is membranoproliferative. Membranoproliferative means number one, GBM will be thickened, and number two, there will be proliferation. So now by light microscopy, what do you see? Number one, you see hypercellular glomerulus. Acha, the glomerulus is hypercellular one. Okay, now why is the glomerulus hypercellular? Due to proliferation of mesangial cells. So glomerulus is hypercellular due to proliferation of mesangial cells. And two, GBM is thickened. So GBM is thickened. Acha, ab yahan par so GBM is thickened. Acha, now light microscopy, glomerulus is hypercellular. Why is it more cellular? Because the mesangial cells are multiplying and the GBM is thickened. Now next question is GBM is, why is the GBM thickened? Now you know this is the GBM, these are the endothelial cells, these are the visceral epithelial cells, and outside what do we have? These are the mesangial cells. Okay, now what happens? These mesangial cells are multiplying. So what do they do? In membranoproliferative glomerulonephritis, the mesangial cells proliferate. When they proliferate, the glomerulus appears hypercellular. Second, what do these mesangial cells do? They proliferate and now they poke their nose into the GBM. That is, they interpose inside. They send their processes into the GBM. And now this GBM appears very thick. So GBM thickening क्यों हो रही है? GBM thickening is, so why is the GBM getting thickened? Due to mesangial interposition. So mesangial cells are interposing into the GBM. So GBM is thickened due to mesangial interposition into the GBM. So mesangial cells are interposing into the GBM. So because of this, the GBM appears thickened. So by light microscopy, glomerulus is hypercellular and this GBM is thickened due to mesangial interposition. Achha, now by light microscopy, by HNE staining, you saw that the glomerulus was hypercellular. Achha, अब हम mesangium thickened है, basement membrane is thickened due to mesangial interposition. We want to see this also. So now do a pass or a silver stain. अच्छा, जब हम pass stain करेंगे, if you see, you know, by pass stain, the whole, this is the GBM, the whole GBM appears pink in color like this. अगर pass stain करेंगे, if this is the GBM, so now if this is the normal GBM which I have drawn, when you do a pass stain, the whole GBM appears pink in color like this. Okay, and by silver stain, pass stain gives GBM a pink color. Muskan, if C3 convertase is stabilized, complement activation will increase, not decrease. Complement, because C3 convertase is stabilized, so it remains active and the complement activation will increase. Okay, so now by pass, what color does pass give to the GBM? Pass gives a pink, rose pink color to the GBM. The whole GBM appears pink in color. Silver stain gives a black color to the whole GBM. Okay, now when there is mesangial interposition, now by pass and silver stain, in MPGN, what will the GBM look like? The GBM will look like this. बीच में क्या है? बीच में थे ये mesangial cells. So mesangial cells. So now pass and silver stain will stain the GBM, but they will not stain the mesangial cells because they are not the stains for mesangial cell. So now what do you see? When you do pass or silver stain, you see tram track appearance. Tram track or double contour appearance. You see tram track or double contour appearance. Why do you see this tram track or double contour appearance in MPGN? Tram track or double contour appearance is due to mesangial cell proliferation and mesangial interposition into the GBM. So it is basically tram track appearance is due to mesangial interposition into the GBM. So the mesangial cells are interposing into the GBM. GBM is appearing thickened, and you see the characteristic by pass and silver stains. You see the characteristic tram track or double contour appearance. Okay. Achha, now this is same. Now let us see type 1 GBM में deposits कहाँ होंगे और type 2 GBM में कहाँ होंगे. In type 1 GBM you have subendothelial deposits. So if you do an immunofluorescence and electron microscopy in type 1 GBM, by electron microscopy you have subendothelial deposits. So you have by electron microscopy, you have subendothelial deposits, and by immunofluorescence, what type of deposits? They are granular deposits. Granular deposits, and again they are granular, so they are granular deposits. Acha, type 2 GBM by electron microscopy, type 2 MPGN. टाइप 2 एमपीजीएन हमने ये पढ़ा था, एमपीजीएन दो तरह का है, टाइप 1 और टाइप 2. लाइट माइक्रोस्कोपिक पिक्चर दोनों में कॉमन है. इलेक्ट्रॉन माइक्रोस्कोपी इन टाइप 2, where the deposits, in type 2 DBM the deposits are inside the basement membrane. So type 2 MPGN, the deposits are in the lamina densa of GBM, basement membrane. Achha, now if you look at the GBM, this is the GBM. GBM has two parts. The central portion, this is called the lamina densa, and peripheral portions of the basement membrane, they are called as lamina rara. So these are the lamina rara. Okay, so now in type 2 GBM, where are the deposits? In type 2 GBM, the deposits are here in the lamina densa. Hence, type 2 GBM is also called dense deposit disease. They are also, type 2 GBM is called dense deposit disease. Okay, so this is membranoproliferative glomerulonephritis. So membranoproliferative glomerulonephritis produces nephritic syndrome, or a picture that is combination of both nephritic and nephrotic. MPGN is of two types: type 1, which follows hepatitis B, hepatitis C, or idiopathic; type 2, which is associated with presence of C3 nephritic factor. C3 nephritic factor is an enzyme that stabilizes C3 convertase. Light microscopy in MPGN, the glomerulus is hypercellular. Why is it cellular? Because of proliferation of mesangial cells, and the GBM is thickened because of interposition of the mesangial cells into the GBM. Pus and silver stains show a tram track or a double contour appearance. Then electron microscopic and immunofluorescence picture is different in type 1 and type 2. Electron microscopy in type 1, we have subendothelial deposits. Immunofluorescence, these deposits appear granular in appearance. In type 2, the deposits are in the lamina densa of the GBM. This is what we see. And coming to the last glomerulonephritis causing nephrotic syndrome, last glomerulonephritis, that is number 6. This is Alport syndrome. Alport syndrome. So last is Alport syndrome. Okay, now what is Alport syndrome? Alport syndrome is an X-linked dominant disorder. It's an inherited condition. X-linked dominant disorder. It's an X-linked. Alport is an X-linked dominant disorder. In Alport syndrome, there is mutation in genes encoding type 4 collagen. You know, GBM is made up of type 4 collagen. So if the genes that produce type 4 collagen, they are mutated, type 4 collagen will not be formed properly. And if type 4 collagen is not formed properly, GBM is abnormal. So there is mutation in the gene encoding type 4 collagen. As a result, the GBM टूटी फूटी हो जाती है, कहीं से thick, thin, और उसमें laminations आ जाती है. So there is thinning. This produces thinning and splitting of the GBM. So this produces thinning and splitting. So GBM टूटी फूटी होती है कहीं से, so it will be something like this. So the GBM becomes very irregular, thinned out, and it may split also. Thinning and splitting of the GBM. Okay, now you know there is mutation in the gene encoding type 4 collagen. Type 4 collagen is found in the basement membranes. Kidney has basement membrane, lung has basement membrane. Type 4 collagen is found in numerous other places. So now these people, they not only have kidney involvement, they have multiple involvement. So now number 1, what are the features? Number 1, they have eye problems. Eye problem में क्या है? इन बच्चों को retinopathy हो जाती है. They have retinopathy and they have lens dislocation. So in eye problem, retinopathy and lens dislocation. Second, kidney, they have glomerulonephritis. So kidney is involved, glomerulonephritis. Third, sensory neural hearing loss. Sensory neural hearing loss. They have sensory neural hearing loss. सेंसरी न्यूरल हियरिंग लॉस. इसके लिए वो यूज करते हैं कांट सी, कांट पी, कांट हियर अ बी. सो कांट सी, so eye problem. Can't pee, this is kidney problem. And can't hear a B, can't hear, अब ठीक से सुनाई देता, can't hear a B. So they can't hear a B, can't see, can't pee, can't be. So this is usually presents in children. And electron microscopy, if you do electron microscopy, the GBM has a characteristic basket weave appearance. Basket weave appearance. GBM has a basket weave appearance. वो टूटी फूटी है, उसमें laminations है, and it is no cure. No curative treatment is available for this entity. No curative. So these are the glomerulonephritis causing nephritic. All the glomerulonephritis causing nephritic syndrome. Okay. So now let us come to few. Okay, so I finished here. Okay, now let us see. Now you tell me a 14-year-old boy. So let us see a few questions and few images. A 14-year-old boy presents with hematuria, problems with vision, deafness. So problems with vision and deafness. Approximately 2 weeks prior to symptom develop, he recovered from viral upper respiratory tract infection. Family history is significant for deafness and early initiation of lisinopril in his father. His temperature is 99 degree, blood pressure is hypertension hai, pulse, respiratory rate is okay. Physical finding is significant for anterior lenticonus and sensory neural hearing loss. So anterior lenticonus, there is lens dislocation and sensory neural hearing loss. Urine analysis shows dysmorphic RBCs and RBC casts. So dysmorphic RBCs and RBC casts indicate glomerulonephritis. So there is glomerulonephritis, there is sensory neural hearing loss, there is lens dislocation, there is deafness running in the family, there is hematuria, there is visual retinopathy hai, visual problems hai, ye sab hai. So this is a characteristic history of Alport syndrome. Okay, then now see this, these are now coming to the images. This is acute post-streptococcal glomerulonephritis. Okay, now look at this glomerulus here. This is the glomerulus. This glomerulus is appearing hypercellular. This is hypercellular glomerulus, and this is electron. These black and white image is electron microscopy. The arrow here, I know this is difficult to understand. यहाँ पे देखो, this is the basement membrane here. This is the epithelial cell, visceral epithelial cell, and the deposits. These are the EP stands for epithelium here. So these are the epithelial cells. So the deposit is somewhere. The arrow shows the deposit. It is, and this is the GBM, and this is the endothelial. These are the endothelial cells. These are the E stands for endothelial cells. So the deposit is sub-epithelial in location here. This is a deposit, and this is the, okay, I'll be showing you a normal glomerulus also just now. So this glomerulus is, this is a glomerular capillary tuft. This glomerulus is very cellular. So this is post-streptococcal glomerular hypercellularity because of leukocytes and proliferation of cells is seen. Okay. Then, okay, now this is, this, look at this picture. This is RPGN or crescentic glomerulonephritis. Now, okay, now look at this picture. Abhi acute post-streptococcal ki dekho, this is the glomerulus and this is the Bowman space here. This is the outside Bowman space is there. Now look at this. Now what do you see? This is the glomerular capillary tuft. All this is the glomerular capillary tuft. This is a silver stain. This is the glomerular capillary tuft. And what do you see outside this glomerular capillary tuft? Something is filling up. This structure is filling this up. This is the picture how a crescent looks like. This is the picture how a crescent looks like. This is a crescent, crescentic glomerulonephritis. This is a silver stain. Silver stain is highlighting the basement membrane of the glomerular capillaries, and also these are the tubules of the kidney. Tubules. Tubular basement membrane is also, all the basement membranes are highlighted in black by the silver stain, and outside now you see, outside the capillaries you see this pink colored crescent shaped structure. This is the crescent. Okay, look at this. This is IgA nephropathy immunofluorescence picture. यहाँ deposits कहाँ मिल रहे हैं? ये जो apple green, bright green color के आ रहे हैं. These are granular deposits which are seen, and they have been done using IgA antibody. When we give such a picture, we'll tell you the antibody also. And these are granular deposits in the mesengium, what you see in IgA nephropathy. Okay. Then this is membranoproliferative glomerulonephritis. Okay, now MPGN, membranoproliferative glomerulonephritis. Okay, now look at this picture. Okay, this is membranoproliferative. This is again a silver stain, black stain aa raha, black color ka aa raha. This is a silver stain. So the glomerulus appears cellular here. This is just proliferative. This is appearing proliferative as in acute post-precoid. It just appears cellular. So this is only giving you information that the glomerulus is cellular. Okay, now look at this picture. Type 1 MPGN. Here, these are subendothelial deposits here. You can see the subendothelial deposits. And these are the subendothelial deposits. And this is type 2 MPGN. That is dense deposit disease. Here, if you see black colored deposits बनाए हैं, they are inside the basement membrane. This is MPGN. Okay. अच्छा, अब वायर लूपिंग हमने किस में पढ़ी थी? हमने वायर लूपिंग पढ़ी थी इसमें. ये है पास टेन. वायर लूपिंग हमने पढ़ी थी, पास टेन पे मिलती है. और डिफ्यूज प्रोलिफरेटिव जैसे SLE में वायर लूपिंग मिलती है. दिस इज हाउ वायर लूप्स लुक लाइक. दीज आर दी बेस. पास टेन इज हाईलाइटिंग द बेसमेंट मेम्ब्रेन्स. These are the basement membrane and they are like wire loops. They are markedly thickened. Otherwise, by pass stain, they should be, basement membrane should be very thin. Look at the tubules. These are tubules here. Look at the tubular basement membrane. This is fine pink in color. These are tubular basement membranes. But look at this glomerular basement membrane here. They are all dark pink loops, wire loops. This is wire loop picture. Okay, now let us come to the question. Okay, let us see these questions now. Few questions. A 62-year-old man presents to his primary doctor complaining of recent onset hemoptysis. Number 1. He had not had any fever, night sweats or weight loss. He recently traveled to Italy with his wife. He has 5-pack per year smoking history. On review of symptoms, he says that his urine is red tinged. Urine analysis reveals figure shown. Figure A में है. He is referred to nephrologist. Renal biopsy is done. This is immunofluorescence picture shown in figure B. Which of the following is the most likely pathogenesis? Okay, now he has history of hemoptysis also. 62 years old male. He has, okay, now look at figure A. Okay, any of you, please, all of you, any of you, what is the answer to this question? Any idea? Any idea? What are we talking about here? और ये इम्यूनोफ्लोरेसेंस पिक्चर देखो क्या लग रही है. ये मैंने अभी तुम्हें पहले दिखाई है. एनी आइडिया? मुस्कान, असद, उज्जवल, प्रीति, परविंदर, एनी आइडिया? I'll give you a break after this. Just 2 or 3 MCQs. I'll give you a break. Any idea what this is? Any of you? Please write in the chat. What is the answer to this question? So there is kidney involvement plus hemoptysis. Okay, good. Preeti has given the answer. Anybody else? Hemoptysis. So there is hemoptysis as well. So this is good pastures syndrome. Okay, now good pasture syndrome. So answer is B, antibodies to type 4 collagen. Okay, now what does figure A show? Now can you see these structures like this? These red colored, these are RBC casts. Casts, you know what is a cast? Number 1, cast is something which is always formed in the tubules of the kidney. Okay, Parvinder also, all of you. Okay, Muskan also, yes, the answer is B. Good pastures. So Rinzin has also given. So I'm very happy all of you have given the answer correctly. उज्जवल ने नहीं दिया. हाँ, उज्जवल ठीक है. परविंदर ने भी दे दिया. ठीक है. अच्छा, अब पहला देखो कास्ट क्या होता है. Casts are always formed in the tubules. Casts अलग अलग तरह की होती हैं. They can be RBC cast, they can be WBC cast, they can be dirty granular cast, they can be fat cast. Now remember, casts will always have parallel. They will always have parallel outlines. Second, now this is an RBC cast because it is made up of RBCs. So this patient is having RBC casts in his urine, plus you may see dysmorphic RBCs also. So that means kidney is involved here. Kidney involvement is there. Achha, second, now look at this immunofluorescence picture. If you see, I showed you this immunofluorescence picture. ये दो बेसिक पिक्चर याद रखनी है. ये पिक्चर, ये पैटर्न क्या था? ग्रैन्युलर पैटर्न. ये पैटर्न क्या है? ये है गुड पैस्चर्स का पैटर्न, एंटी जीबीएम डिजीज का पैटर्न है ये, एंटी जीबीएम. और ये क्या है? ग्रैन्युलर पैटर्न. अच्छा, ग्रैन्युलर पैटर्न, ये ग्रैन्युलर पैटर्न कहां मिल सकता है? ये ग्रैन्युलर पैटर्न मिल सकता है एक्यूट पोस्ट स्ट्रेप्टोकोकल ग्लोमेरुलोनेफ्राइटिस में ग्रैन्युलर पैटर्न मिलेगा. आरपीजीएन में भी मिल सकता है, बट आरपीजीएन अगर गुड पैस्चर्स की वजह से है तो दिस पैटर्न विल बी सीन. डिपेंडिंग ऑन द कॉज ऑफ आरपीजीएन यू विल गेट द पैटर्न. ओके, सो दिस you will see. Then in wire looping will be seen in acute post streptococcal. Okay, then IgA nephropathy also you have a granular pattern, but it will not be like this. Look at the pattern in IgA nephropathy. This is the granular pattern, but this is different granular pattern of IgA nephropathy. So now if you come back to this question, see the pattern. This is the correct, learn of this pattern. This is the characteristic pattern of good pastures syndrome. Okay, next question. 2. A 6-year-old boy presents to your office with hematuria. So 6 years old, 2 weeks ago he had symptoms of sore throat and fever. Although physical examination is unremarkable, laboratory studies show decreased C3 level, elevated anti-DNase B titer. So ये ASLO titer जैसे करते हैं, ऐसे ही anti-DNase B titer है. Which of the following would you expect to see on a renal biopsy? Answer. All of you please write your answer quickly. सभी लोग आंसर लिखो इसका, और बाकी ऑप्शंस का भी आंसर डिस्कस करेंगे. सो इसका आंसर क्या है? पहला तो ये एंटिटी क्या है? ऑल ऑफ यू क्विकली राइट योर आंसर. रिंजिन, मुस्कान, परविंदर, उज्जवल, प्रीति, नेहा इज नॉट राइटिंग एनीथिंग. सब लोग आंसर लिखो इसका क्विकली, चैट पे आंसर लिखो. अच्छा, now what is this? All of you please write your answer. Okay, now answer to this is A. So this is acute post streptococcal glomerulonephritis, characteristic history. Okay, acute post streptococcal. So Rinzin has given the answer. Yes, you are correct. It's A, acute post streptococcal glomerulonephritis. In acute post streptococcal glomerulonephritis, the glomerulus is hypercellular. So large hypercellular glomeruli. Why are the glomeruli hypercellular? Because the endothelial cells are proliferating, the mesangial cells are proliferating, and neutrophils and monocytes are also jumping and coming. So there is option B. किसमें मिलेगा? Polyclonal IgA deposition on by immunofluorescence. This will be seen in IgA nephropathy. Immune complex in spike and dome pattern. अच्छा, अभी हम आगे पढ़ेंगे. Okay, प्रीति, मुस्कान, okay, परविंदर, all have given the answer. You are correct. Okay, अभी हम आगे पढ़ेंगे spikes and domes. Spike and dome pattern. This is characteristic of which we will read just now. Membranous glomerulonephritis या membranous glomerulopathy. Spike and dome pattern अभी मैं पढ़ाऊंगी. Membranous glomerulopathy. Wire looping is a feature of diffuse proliferative glomerulonephritis, which you see in SLE. And anti-GBM antibodies in a linear fashion. Okay, so Yalini, good. So it is acute post streptococcal. She's also given the answer. Antibodies to GBM resulting in linear immunofluorescence pattern. This is in good pastures. Good pastures. Okay, this is question 2. Okay, coming to question 3. Okay, this is just an history. A 6-year-old boy is brought to emergency department by his mother due to swelling around his eyes and legs. So periorbital edema bhi hai, legs mein bhi hai. Mother says that the patient recently recovered from upper respiratory tract infection. Okay, so serum C3. Yes, serum C3 levels are associated with MPGN. Yalini has asked me. Okay, C3 levels are associated with, in fact, in patients with MPGN, they have C3 nephritic factor in their urine, and in their blood, serum C3 levels are reduced. Serum C3 levels are reduced because C3 is getting used up. So there is a lot of C3 convertase, so C3 is getting used up, serum C3 levels are reduced. Okay, a 6-year-old boy is brought to emergency department by his mother due to swelling around his eyes and legs. Mother says that he had upper respiratory tract. Physical examination shows periorbital and lower extremity edema. There is hypoalbuminemia and normal complement levels. Urine shows 4+ proteinuria. Achha, okay, now this is the next question for the we'll be doing next time FSGS. तो चलो अभी यहाँ तक है. ये अगला है मिनिमल चेंज डिजीज का क्वेश्चन. ये अभी मैंने पढ़ाया नहीं है. सो मिनिमल चेंज डिजीज. ओके, minimal change disease. Okay, so we'll do this after the break. So you can take it's 7:18. All of you can take a 10 minutes break. We'll assemble at 7:28. All of you, we will assemble at 7:28. I hope you are all back. I hope you are all back. If you have joined, please say yes. Write on the chat. Okay, now Yalini has asked me a question. Please say yes on the chat. Please say yes, all of you. Okay, all of you are back. Okay, मैं बाद में बात करूंगी लेक्चर. Okay, now, I want to tell you something. Yalini had asked me a question. There is some confusion about C3. Okay, now remember, in all these glomerulonephritis, they are immune mediated. There are immune complexes. Immune complexes, what will they contain? Immune complexes will contain antibodies and complement component. And complement can be activated by classical or alternate pathway. अच्छा, अब acute post-streptococcal glomerulonephritis में जो deposits थे immunofluorescence पे, granular deposits containing IgG, IgM and C3. Now C3 is found in the glomerulus. So C3 is getting used up. So serum levels decrease. C3 will be found in the blood. अच्छा, IgA nephropathy में what do the deposits contain? They contain IgA antibody. The deposits are mesangial in location. They contain IgA plus they contain C3 of alternate pathway. Alternate pathway. So दो बीमारियां हैं जिसमें alternate pathway की activation होती है, वो है IgA nephropathy और MPGN type 3. So in IgA nephropathy, if you see by immunofluorescence, you get IgA antibody plus C3 of alternate pathway. अच्छा, in IgA nephropathy, blood level of C3 may not be reduced. It may still be normal, but C3 of alternate pathway will be deposited along with IgA antibody in the mesangium. Whereas in acute post-streptococcal, it is IgG, IgM, C3. This is classical pathway now. Wherever it is alternate, I will mention. Alternate is only in two. So, in acute post-streptococcal glomerulonephritis, you have IgG, the granular deposits on immunofluorescence contain IgG, IgM and C3, and C3 levels in the blood are reduced. In IgA nephropathy, IgA antibody plus C3 of alternate pathway, blood levels of C3 may not be reduced. In diffuse proliferative, IgG plus C3, again C3 of the normal classical pathway, and C3 may be decreased in the blood, may or may not. RPGN की varied morphology है. MPGN type 1 may the deposits contain IgG plus C3 of classical pathway. Classical pathway जो और सब में classical pathway है. And in type 2 now you only have the deposits contain only C3 of alternate pathway and their blood levels of C3 decrease. So these people, they have decreased serum levels of C3 plus they have this C3 nephritic factor in their blood, So serum C3 levels decreased है और C3 nephritic factor भी है. So blood में C3 level कम आएगा. C3 जो है ये IgA nephropathy और MPGN type 2 में कौन सा C3 मिलता है आपको? ऑल्टरनेट पाथवे का C3 मिलता है और बाकी सब में क्लासिकल पाथवे का C3 मिलता है. और कौन सी कंडीशंस में ब्लड में C3 लेवल कम हो जाएगा? एक्यूट पोस्ट स्ट्रेप्टोकॉकल में ब्लड में C3 लेवल कम हो जाएगा. फिर MPGN में टाइप 2 में ब्लड में C3 लेवल कम हो जाएगा. टाइप 1 में भी ब्लड में C3 लेवल कम हो सकता है, लेकिन that may or may not be. Same as with diffuse proliferative glomerulonephritis. So I hope, Yalini, this clears your doubt. I hope this clears your doubt. Okay, now let us come to nephrotic syndrome. Nephrotic syndrome. Okay, nephrotic syndrome. What are the features of nephrotic syndrome? Nephrotic syndrome is characterized, number one, by proteinuria. Okay, now this is massive proteinuria. So massive proteinuria. That means there is loss of more than 3.5 grams per day of protein in the urine. So how much protein is lost in the urine every day? More than 3.5 grams per day. अच्छा, अब जब इतना protein loss हो रहा है, and which is the protein that is lost? Most commonly it is the albumin. So this results in hypoalbuminemia. So amount of albumin in the blood decreases, and this results in edema. So this results in edema. Okay, this results in edema. Third important feature, they have hyperlipidemia. They have lots and lots of triglyceride and cholesterol in their blood. Okay, now they have lot of triglycerides in their blood. Okay, now why is there this hyperlipidemia? Because your doubt? Why is there hyperlipidemia? This is because, there is proteinuria. Proteins are lost in the urine. To compensate for loss in protein, the body is compensating that by manufacturing more lipid. So now there is hyperlipidemia. What does this lead to? There are so much lipids in the blood. The lipids are excreted in the urine. So in the urine, you have frothy urine. So there is frothy urine. So urine becomes frothy, plus there are fatty casts in the urine. So there is hyperlipidemia. Achha, fourth feature, there is hyperlipidemia. Achha, fourth is, now a number of proteins are lost in the urine. Which is the most common protein lost in the urine? Albumin. So there is proteinuria with loss of albumin. In addition to albumin, antithrombin 3. So there is, because of protein, the proteins lost in the urine kaun se hai? Proteins lost in the urine. Proteins lost in the urine are number 1 albumin, low molecular weight albumin. This leads to hypoalbuminemia and edema, which I have already written. Second albumin lost in the urine is transferrin. Second protein lost in the urine is transferrin. You know transferrin is iron transporting protein. So nephrotic syndrome patients can develop iron deficiency anemia. They can develop iron deficiency anemia. Third protein lost in the urine is antithrombin 3. Antithrombin 3. You know what is antithrombin 3? It's a naturally occurring anticoagulant. So what is antithrombin 3? I have already told you in your previous class, this is naturally occurring anticoagulant. So this is an anticoagulant, normal anticoagulant, which we all have. Now if this anticoagulant is lost, this leads to thromboembolism, thrombosis. So renal vein thrombosis हो जाता है इन बच्चों को nephrotic syndrome में. This results in thromboembolism. So this results in thromboembolism. And fourth, antibodies are also lost in the urine. So immunoglobulins are also lost in the urine, and loss of immunoglobulins leads to increased risk of infections. So this is nephrotic syndrome. Features of nephrotic syndrome: massive proteinuria. How much proteins are lost in the urine? More than 3.5 grams are lost per day. Hypoalbuminemia, which leads to edema. Hyperlipidemia, because proteins are not there, so more lipids are synthesized. So urine becomes frothy and there are fatty casts in the urine. And you know, ये जो fatty casts होती हैं, इसका characteristic बोलते हैं Maltese cross sign. So these fatty casts in the urine, they produce Maltese, M-A-L-T-E-S-E, Maltese cross sign. So this produces the characteristic Maltese cross sign. Okay, then proteins that are lost in the urine are albumin, which leads to hypoalbuminemia and edema. Transferrin is lost, leading to iron deficiency anemia. Antithrombin 3 is lost, leading to renal vein thrombosis and thromboembolism. Antibodies are lost in the urine, which leads to increased risk of infection. Okay, now let us see causes of nephrotic syndrome. Causes of nephrotic syndrome can be primary. So primary glomerulonephritis can cause nephrotic syndrome, or causes can be secondary. अच्छा पहले primary देखते हैं तो कौन सी glomerulonephritis है जो cause करती है nephrotic syndrome. इसमें आता है number 1, minimal change disease. This is the primary disease of the kidney, of the glomeruli, causing nephrotic syndrome. Second is focal segmental glomerulosclerosis. Third is membranous nephropathy. Okay, these are primary glomerulonephritis causing nephrotic syndrome. Coming to secondary conditions. Secondary diseases that involve the kidney and produce glomerulonephritis. They damage the podocytes and produce nephrotic syndrome. So these two are number 1, very important ones are number 1, diabetes mellitus, and second, amyloidosis. So diabetes and amyloidosis. So these are diabetes and amyloidosis. So now let us start first with minimal change disease. So first is minimal change disease. So minimal change disease is the most common cause of nephrotic syndrome in children. So minimal change disease is the most common cause of nephrotic syndrome in children. And etiology, it can be primary or idiopathic. It can be idiopathic or it can be secondary also, idiopathic or primary. And you know, this idiopathic or child will give you the characteristic history कि nephrotic syndrome generalized edema कब हो गया. And this primary or idiopathic is triggered by a recent infection, immunization, or any other immune stimulus. So this is triggered by infection or by recent infection, or by immunization. So the child gives the history, so infection or by recent history of allergy also. So कोई infection हो गया, recent infection है उसके बाद हो गया, या immunization कराया उसके बाद nephrotic syndrome हो गया बच्चे को, या allergy के बाद हो गया. Or it can be secondary. Secondary nephrotic syndrome can be seen in patients of lymphomas. So this can be seen in patients with lymphomas. So, and third, there is a hereditary nephrotic syndrome or hereditary minimal change disease also, which is called as Finnish syndrome. Finnish syndrome, which is a genetic disorder. Hereditary is Finnish syndrome. Okay, in nephrotic syndrome, if you see by light microscopy, glomeruli are normal. Glomeruli is absolutely normal. Glomeruli is absolutely normal, hence the name minimal change disease. But if you look at the tubules, the PCT cells are laden with fat. They contain fat in their cytoplasm. Hence the name, another name for nephrotic syndrome is lipoid nephrosis. So PCT cells are laden with fat, hence the name lipoid nephrosis. Okay, this is light microscopy. Electron microscopy, no deposits. Only thing that you see is, now you remember this figure, I always draw this. These are the visceral epithelial cells or podocytes. This is the GBM, these are the endothelial cells. Acha, up electron microscopy, number one, no deposits anywhere. No deposits. Two, only change that you see is now this. What has happened to this foot processes? They have got ironed out, they have become flattened. So effacement of foot processes, of podocytes. That is the only change that you see. Hence, because there is nothing on immunofluorescence, there is hardly any change on light microscopy. Only change, little change that you see is effacement of foot processes. Hence the name minimal change disease or lipoid nephrosis or nil disease bhi bolte hain isko. So these are the lipoid nephrosis or nil disease. Okay, so this is the most common cause of nephrotic syndrome in children. And remember, last, the bachcho mein jo hota hai primary nephrotic syndrome, which is seen in children, which follows immunization, which is idiopathic, has excellent response to corticosteroids. Has an excellent response to corticosteroids. So they recover very well with corticosteroids. Coming to second is focal segmental glomerulosclerosis, FSGS. I have already told you what does this mean. Okay, now minimal change disease mein how will the child present? Child will present with most common cause of nephrotic syndrome. Ab FSGS. You already know the meaning. There is focal and segmental sclerosis of glomeruli. So there is sclerosis, there is focal and segmental sclerosis of glomeruli. So the glomeruli show focal and segmental sclerosis. So there is focal and segmental sclerosis of the glomeruli. So segmental sclerosis and hyalinosis of the glomeruli. So focal and segmental sclerosis of the glomeruli is what you see by light microscopy. Okay, now clinical features. Okay, clinical features, how does the patient present? Nephrotic syndrome, or they may just come with non-nephrotic range, just with proteinuria. Non-nephrotic range proteinuria. So just with non-nephrotic range proteinuria. Okay, now most common cause of nephrotic syndrome in African Americans and Hispanics. So most common cause of nephrotic syndrome in African Americans and Hispanics. Okay, now cause, etiology can be primary और सेकेंडरी. अच्छा, अब प्राइमरी में क्या क्या आता है, ये इंपॉर्टेंट है. पेशेंट्स विद HIV कैन हैव FSGS. पेशेंट्स विद सिकल सेल एनीमिया, हीरोइन अब्यूज, इसके स्पेसिफिक कॉजेज हैं. हीरोइन अब्यूज, मैसिव ओबेसिटी, massive obesity. Treatment with interferon treatment. Interferon treatment. So interferon patients with, or it can be secondary, so it can be, this is secondary, this is not primary. So primary is idiopathic. Primary is, you don't know the cause, primary is idiopathic, or it can be secondary, and in secondary these are the causes. So for secondary, primary is idiopathic, for secondary we have these causes. So HIV, sickle cell anemia, patients of sickle cell anemia can have it, heroin abuse, massive obesity, or treatment with interferon treatment. All these people can have this, and usually this progresses to chronic renal disease. It progresses to chronic renal disease. Okay. Achha, ab light microscopy, what do you see? We already know focal and segmental sclerosis and hyalinosis. Hyalinosis means pink material is deposited in the glomeruli. So fibrous tissue, pink material. Okay, now electron microscopy, effacement of food processes. Just like minimal change disease, there is effacement of food processes of podocytes. So effacement of food processes of podocytes. And immunofluorescence often negative, usually negative, often negative, but it may be positive, and there is non-specific specific focal deposits of IgM C3 and C3, where in areas of hyalinosis, in areas of scarring or fibrosis. So in areas में IgM C3 can deposit in the areas of scarring. So this deposition may be seen in the areas of scarring. So this is focal segmental glomerulosclerosis. Okay, so this is number second. Coming to the third entity in this category. Third is membranous glomerulopathy. Membranous glomerulopathy or membranous glomerulonephritis भी बोल देते हैं. Okay, membranous glomerulonephritis, most common cause of nephrotic syndrome in African Americans and Hispanics is focal segmental glomerulosclerosis. Most common cause of primary nephrotic syndrome in Caucasians is membranous glomerulopathy, and most common cause of nephrotic syndrome in children is minimal change disease. So this is the most common cause of primary nephrotic syndrome in Caucasian adults. Again, etiology or causes. Okay, now again causes can be primary. Causes can be primary. Primary is seen in patients, example, who have antibodies to phospholipase A2 receptor. Antibodies to phospholipase A2 receptor. Achha, or it can be secondary. Secondary can be to drugs. अच्छा, इसमें अब ड्रग्स का नाम अच्छे से याद करना है. सो इट कैन बी टू ड्रग्स में कौन कौन सा आता है? NSAIDs एंड पेनिसिलामीन. NSAIDs or penicillamine, or it can be secondary to infections like hepatitis B, hepatitis C. Third, it can be secondary to other diseases, very important, SLE. And then fourth, it can be to solid tumors also. And again, this can also progress to chronic renal disease. It can progress to chronic renal disease. अच्छा, अब फाइंडिंग्स देखते हैं. लाइट माइक्रोस्कोपी, इसका नाम है membranous. So membranous क्या होगा? There will diffuse thickening of the capillary and the GBM. So diffuse capillary wall या capillary and GBM thickening. So hence the name membranous. अच्छा, then electron microscopy. Where are the deposits? Okay, now the deposits are So there is, by light microscopy, diffuse capillary wall and GBM thickening. So diffuse capillary wall and GBM thickening. GBM thickening, how will you see? By pass or by silver stain. HNE पे क्या दिखेगा? Diffuse capillary wall thickening. Capillary wall thickening. So you will just see that the capillary walls are thickened. By pass and silver stain, you will be able to identify that this thickening is in the GBM. Okay, electron microscopy, what do you see? We see a characteristic spike and dome pattern of deposits. Spike and dome appearance with subepithelial deposits. So where are the deposits? They are subepithelial. So there are subepithelial deposits producing a characteristic spikes and domes pattern. So spike and dome pattern. And immunofluorescence में deposits कैसे हैं? They are granular deposits. So they are granular deposits. So this is what we see in membranous glomerulonephritis. Fourth very important entity that causes nephrotic syndrome is diabetes mellitus. अच्छा, अब diabetes में दो तीन चीजें याद रखनी है. Diabetes can cause a number of changes in the kidney. Number one, and you by light microscopy, what do you see? Number one, just GBM thickening. Diabetes can only cause GBM thickening. Second, diabetes can cause mesangial expansion. Okay, now third, diabetes can cause what you call as nodular glomerulosclerosis. Nodular glomerulosclerosis is also called as Campbell-Steele-Wilson disease. Nodular glomerulosclerosis is also called as Campbell-Steele-Wilson disease. Achha, now what is this nodular glomerulosclerosis or Campbell-Steele-Wilson? I will be showing you a picture of this. Okay, all these lesions, so I will show you the picture. In the capillary loops, pink colored nodules are formed. So if these are the capillaries, these are the capillaries here. These are the glomerular capillary tuft. Now here if you see in these areas in the mesangium, pink colored nodules are formed. So nodular glomerulosclerosis mein there are nodules, pink nodules in the mesangium. Of peripheral capillaries. जो बाहर की तरफ capillaries हैं, उन capillaries के बीच में जो mesangium है उसमें गुलाबी nodules बनते हैं. In the peripheral capillaries. This is called as this is termed as Campbell-Steele-Wilson disease. And what is the cause? Why is the GBM thickened in diabetes? GBM is thickened because of, there is non-enzymatic glycosylation of GBM. So there is non-enzymatic glycosylation. Non-enzymatic glycosylation of GBM. So this damages the GBM and this increases the permeability. This increases the permeability of GBM. Okay, this increases the permeability of GBM. So now this is the diabetic mellitus or diabetic glomerulonephropathy. Diabetic glomerulonephropathy. This is the most common cause of end-stage kidney disease. Most common cause of end-stage kidney disease. In countries like US. So in countries like US. So this is the most common cause. Okay, so अच्छा, अब mesangial expansion भी होता है. Again, why is there mesangial expansion? We wrote there is mesangial expansion. Again, mesangial expansion is also due to non-enzymatic glycosylation of efferent arterioles. So this is also due to non-enzymatic glycosylation of GBM causes GBM thickening. Non-enzymatic glycosylation of efferent arterioles. So non-enzymatic glycosylation of efferent arterioles causes the mesangial expansion. So GFR will increase and that will cause the mesangial expansion. Okay, last entity in this category is amyloidosis. We have already covered amyloidosis. Kidney can be involved by amyloid. So kidney is the most common organ involved in secondary amyloidosis, in systemic amyloidosis. So in systemic amyloidosis, multi-system disorder है. Most common organ involved is kidney. Kidney can be involved both in primary amyloidosis. Primary amyloidosis किसमें मिलता था? This was seen in multiple myeloma. Multiple myeloma. And in multiple myeloma, the substance that was deposited as amyloid was AL type of amyloid. Light chains are deposited as amyloid. So AL type of amyloid. Second, kidney can also be involved in what you call as secondary amyloidosis. Kidney can also be involved in secondary amyloidosis, which you see in patients with chronic inflammatory conditions. And here it is AA type of amyloid. AA type of amyloid is seen. Okay, so AA type of amyloid is seen. So now this finishes with nephrotic syndrome. This finishes with the nephrotic syndrome. Okay, now I hope all of you have understood the glomerulonephritis, causes of nephrotic syndrome, nephritic syndrome. I hope you've all understood. Okay, now let us come to a few questions here. Okay, a 6-year-old boy is brought to emergency department by his mother due to swelling around the eyes and legs. The patient has recovered from urinary tract infection. Physical examination shows periorbital and lower extremity edema. There is hypoalbuminemia and normal complement levels. Urine analysis shows 4+ proteins. A presumptive diagnosis of minimal change disease is made and the patient is started. So this is just to tell you how the question is. We'll see the question. Okay, now this is minimal change disease. Photo. ये क्या है जो black color है? This is silver stain. We have stained the GBM by silver stain. So when viewed by silver stain, the glomerulus is absolutely normal. So this is again normal. And if you see, look at this schematic diagram. What you see is only foot processes of podocytes are effaced. Rest everything is okay. Only the foot processes of podocytes are lost. Rest all is okay. There is effacement of foot processes of podocytes. Okay. अच्छा, अब ये है focal, हाँ. Okay, now look at this. This is the picture how FSGS will look like. This is focal segmental. Now this is the glomerulus here. Glomerulus here. Now this is again pars stain. Pars stain. Now these are the tubules. These are the tubular basement membrane here. Okay, now look at this glomerulus. You are seeing so much of pink material everywhere. So now see collection of scarred obliterated capillaries. So look at these capillaries here. You can't make out these capillaries properly. They are scarred and obliterated capillaries. And accumulation of matrix. So this portion of the glomerulus, this is focal and segmental involved. This is the segmental involvement. This segment of the glomerulus is involved. Pink material is there. This pink material is there. All the capillary loops in this area where there is pink material, they are obliterated. So this is focal segmental glomerulosclerosis. Okay, FSGS. Okay, now this is picture of membranous. This, अच्छा इसको भी याद करना है. ये है membranous glomerulopathy. So membranous glomerulopathy में ये भी pars stain है. यहाँ पर क्या है? This GBM is thickened. Capillary wall, the whole capillary walls are thickened. So GBM is thickened by pars stain. And if you see here, podocytes are effaced, and where are the deposits? These black colored deposits, they are subepithelial. And the basement membrane GBM is thickened. Number one. Number two, the deposits are subepithelial in location, and this is spikes and domes. What are spikes? The deposits, these black deposits are dome shaped, and in between the GBM, the portion of GBM that is projecting between these domes, this is forming the spikes. So domes are the deposits, spike and dome pattern. So spikes क्या है? तो GBM का material domes के बीच में है, deposits के subepithelial deposits में जो GBM का material है उसको कहते हैं spikes. So spike and dome pattern. Okay, Muskan, I will explain in the end about C3 again. What you have asked me, I'll explain in the end. Okay, so this is membranous glomerulonephritis. Okay, now this is Kemmel-Steele-Wilson disease. Beautiful. This is pars stain. This is Kemmel-Steele-Wilson disease is seen in diabetes. This is also called nodular glomerulosclerosis. These are the nodules, pink colored nodules in the glomeruli, pink material. This is Kemmel-Steele-Wilson disease. Peripheral capillary loops के mesenterium में ये गुलाबी रंग का deposit हो जाता है. ये silver stain है. Silver stain है. इसमें ये देखो pink nodules. These are the nodules which you see. This is Campbell-Steele-Wilson disease. Okay, now you have to identify these figures. Okay, a 52-year-old African American male with history of HIV and obesity presents to his primary care physician because of recent change in his health. He states that while he was compliant on HIV medication, he has noticed recent fatigue and swelling in face and legs. A routine urine analysis shows proteinuria and fatty cast. So proteinuria and fatty cast. Based on these findings, the physician decided to do a kidney biopsy. अब बताओ इसमें कौन सा kidney biopsy का figure fit होता है? Figure 1. Look at figure 1. This is figure 1. This is figure 2. This is figure 2. Then this is figure 3. Figure 3. Then figure 4. This is figure 4. And this is figure 5. Figure 5. So first try and see which glomerulonephritis are we talking about here. So all of you please tell me your answer. Look at figure 1 and 2. First look at figure 1 and 2. Which one will fit? Figure 1, figure 2, figure 3, 4 and 5. Okay, please write your answer. What do you think is the answer to this question? I'll just show you these few. Okay, what do you think is the answer to this question? Figure 1, 2, 3, 4, 5. Figure 1, 2, 3, 4. Okay, figure 1. Anybody else? 2. Preeti 2. Okay. Parvinder figure 2. Muskan. Okay. Yalini, what is your answer? Ujjwal? Yalini and Ujjwal? Okay, Muskan has given the answer. Okay. What about Yalini and Ujjwal? Okay, so, okay, answer is figure 2. Okay, now what is this? This is FSGS. FSGS. Okay, now look at figure 2. Now here this is the focal and this is the segmental sclerosis of the glomeruli that we are seeing here. Okay, so Ujjwal has also given. अच्छा अब figure 1 क्या? आप सारे figures देखो. Figure 1 क्या है? ये पास स्टेन लगाया हुआ है हमने, लेकिन ये normal glomerulus है. ये नॉर्मल ग्लोमेरुलस है. अच्छा फिगर 3 देखो, ये आपको इसका आंसर है फिगर 2. आंसर है फिगर 2. अच्छा फिगर 3 देखो, ये देखो, ये अभी हमने ऊपर देखा था फिगर 3. ये है फिगर 3. ये क्या है? Campbell-Steele-Wilson disease. So Yalini has also given. Good. So ये है फिगर 3. This is Campbell-Steele-Wilson disease. Campbell-Steele-Wilson disease. So you can see these nodules of pink material. Okay. Look at this figure 4. This is figure 4. This is the glomerulus here. This is actually, it is not very clear here. This is actually RPGN, crescentic glomerulonephritis. Here, this is all a crescent here. This is the glomerular capillary tuft and this is the crescent here. And ये जो figure 5 है, यहाँ पे ये जो figure 5 है, this is अभी हमने ऊपर देखा था, this is membranous glomerulopathy, glomerulonephritis. See this figure 5. I showed this figure. This is figure from the textbook. This is figure 5. Membranous glomerulonephritis. Okay. So answer to this is FSGS and that is figure 2. Okay. Then look at question 3. A 55-year-old African American male presents to his primary care physician with persistent low back pain and fatigue over 12 months. Physical examination shows a blood pressure of 190 by 150. He has hyperlipidemia. Serum creatinine is 3 mg/%. 4.5 grams of proteins are excreted in the urine every day. So he has nephrotic syndrome, plus he has hypertension also. His serum creatinine is also elevated. Renal biopsy shows eosinophilic acellular material in the glomerular tuft and capillary walls that has an apple green colored birefringence with Congo red staining. The patient most likely suffers from which of the following? Answer very simple. Question 3 का आंसर लिखो फटाफट सब लोग. Question 3 का आंसर लिखो. Please write the answer to question 3. Okay, so now Congo red staining, this is the story of amyloidosis. So this is multiple myeloma. Patients of multiple myeloma end up with primary amyloidosis. Okay, question 4. Okay, now question 4. Question 4, we'll look at question 4. So let us look at kidney stones. So question 4 we'll do with kidney stones. Okay, quickly, that's simple. Let us look at kidney stones. Kidney stones. Achha, so you, okay, so everyone has, okay, Rinzin has answered B. B कौन सा? B कैसे बोला है? B क्या है? B किसका आंसर बोला आपने? Okay, so answer to that question was multiple myeloma, Congo red positive, that was amyloidosis. Okay, coming to kidney stones. Okay, kidney stones, if you know, if there are stones in the kidney, complications of kidney stones can be hydronephrosis and infection of the kidney, that is pyelonephritis. Yes, Parvinder, the answer is D. Ujjwal and Rinzin, why have you called it B? That's amyloidosis of the kidney. Amyloid deposition, Congo red positive. So that is amyloid, and amyloidosis अभी मैंने पढ़ाया था. amyloidosis किस में मिलता है? ये देखो, अभी हमने amyloidosis में पढ़ा था ऊपर. Diabetes and amyloidosis. Kidney can be involved in systemic amyloidosis. Amyloidosis can be primary, which is seen in multiple myeloma, where AL type of amyloid is deposited in the kidney, or it can be secondary. AL type of amyloidosis multiple myeloma में होता है, और secondary amyloidosis amyloid के chapter में मैंने पढ़ाया हुआ है, इसलिए I did not elaborate. AA type of amyloid is deposited in the kidney. Okay, now kidney stones. If there are stones in the kidney, they can, what are the complications that they can present? They can present with hydronephrosis and pyelonephritis. And clinical feature क्या होगा kidney stones का? Unilateral flank pain. Unilateral flank tenderness. One tenderness. Then stones produce colicky pain. Colicky pain. So there will be colicky pain radiating to the groin. Radiating to groin. So colicky pain radiating to groin and hematuria. So stones will cause passage of blood in the urine. And you know, patients who have kidney stones, you should ask them to drink lot of water. Drink lot of water. Most common stones. So अब कौन-कौन से stones मिलते हैं kidney में? Most common stones in the kidney are calcium stones. They are calcium stones. अच्छा, दो तरह के calcium stones मिलते हैं kidney में. Calcium oxalate and calcium phosphate stones. Calcium oxalate and calcium phosphate stones. So calcium oxalate stones and calcium phosphate. अच्छा, calcium oxalate stones जो हैं, they are radio opaque. You by CT as well as by X-ray, they are radio opaque. Calcium phosphate are also radio opaque stones. Both are radio opaque stones. अच्छा, अब जो calcium stones हैं, usually 80%, as I've told you, 80% are calcium oxalate. Out of the calcium stones are calcium oxalate stones. Okay, now calcium stones are most common. Calcium oxalate are more common than. So 80% of the stones in the kidney are calcium stones. 80% stones, 80% kidney stones. यहाँ लिखना चाहिए 80%. यहाँ 80% kidney stones are calcium oxalate, are calcium stones, and calcium stones can be calcium oxalate or phosphate, and calcium oxalate is more common than calcium phosphate. Okay, now ये जो these stones, they are associated with decreased urine pH. So pH कैसा है? These stones are formed in decreased urine pH. So and another factor associated is hypocitraturia. So decreased urinary pH and hypocitraturia. Hypocitraturia, this can be seen in hypocitraturia, and hypocitraturia is associated with decreased urine pH, and they can also result from vitamin C abuse or other causes. So hypocitraturia is there. Okay, now if there are stones in the kidney, urine can show crystals. So crystals can be seen in the urine. Calcium oxalate crystals. Calcium oxalate crystals की shape जाननी है. They are envelope or dumbbell shaped. So I'll be showing you the picture, envelope or dumbbell shaped. Dumbbell shaped. Bell shaped crystals. So calcium oxalate crystals are envelope or dumbbell shaped crystals. और calcium phosphate जो है उसके crystals की shape कैसी है? Wedge or prism shaped. Wedge or prism shaped. Prism shaped. So most common kidney stones are calcium stones. Calcium stones are radio opaque. By CT also and by X-ray also they are radio opaque. Calcium stones are associated with hypocitraturia. And if there are calcium stones in the kidney, crystals, corresponding crystals will be found in the urine. कैल्शियम ऑक्सलेट क्रिस्टल्स की शेप कैसी होती है? डम्बल शेप्ड होते हैं. कैल्शियम फॉस्फेट क्रिस्टल्स की शेप कैसी होती है? वेज या प्रिज्म शेप्ड. अच्छा, दूसरे तरह के स्टोन्स कौन से मिलते हैं किडनी में? अमोनियम मैग्नीशियम फॉस्फेट. अमोनियम मैग्नीशियम फॉस्फेट. अमोनियम मैग्नीशियम फॉस्फेट स्टोन्स. सो अमोनियम मैग्नीशियम फॉस्फेट स्टोन्स. अच्छा, अब इसका इंपॉर्टेंट पॉइंट क्या है? They are formed in increased pH. So increased urinary pH. Again, these are also radio opaque. These stones are also radio opaque, and the corresponding crystals, calcium, magnesium, phosphate, इसको crystals that are found. So ammonium, magnesium, phosphate crystals that are found, they are coffin lid. They look like coffin lid shaped. Crystals are coffin lid shaped. Okay. Another name for this ammonium magnesium phosphate crystals are, they are also called struvite stones. Struvite stones. They are also called as struvite stones, and these ammonium magnesium phosphate stones, they account for 15% of renal stones. So 80% of renal stones are calcium stones. So they account for 15% of renal stones. And now these stones, very important, these stones are caused by urease, they are caused by infection. UTI की वजह से हैं, caused by infection with urease negative organisms, urease negative bacteria. Infection by urease negative bacteria like Proteus. So which are the urease negative bacteria? Proteus mirabilis. Proteus mirabilis. Then you have the Staphylococcus, Saprophyticus, Staph Saprophyticus, and Klebsiella. So they are caused by these, and you know they hydrolyze urea to ammonia, so they make the urine alkaline. So they hydrolyze urea to ammonia and make the urine alkaline. और ये जो है अमोनियम मैग्नीशियम या स्ट्रूवाइट स्टोन्स, दे ऑल्सो फॉर्म स्टैगहॉर्न कैल्कुलाई. Look, staghorn calculi that which completely fill the pelvic ileal system. So commonly the staghorn calculi are these stones, and treatment is to treat the underlying infection and to remove the stones. Third type of stones are uric acid stones. So third type of stones that we see are, so stones are very simple. You can uric acid stones. Uric acid stones. Okay, now uric acid stones, again they are formed in decreased pH whenever the pH of the urine decreases. Now uric acid stones are radiolucent. They are not radio opaque, they are radiolucent. And they are by CT. So X-ray pe they are radiolucent, by CT they are minimally visible. They are minimally visible. So they are minimally visible. अच्छा, corresponding crystals are found in the urine. Crystals कैसी होती हैं? Rhomboid or rosette shaped. Rhomboid or rosette shaped. Rosette shaped crystals are there. अच्छा, about uric acid stones जो हैं, they constitute 5% of kidney stones. Of kidney stones. 5% of kidney stones, and you know they have a strong association with, cause क्या है? Strong association with hyperuricemia. So in conditions where uric acid level in the blood increases, hyperuricemia as in gout, so they can be seen in gout. One, hyperuricemia due to gout, and second, whenever there is increased cell turnover as in increased cell turnover as in leukemias. So in leukemias also, patients of leukemias can also develop this. और इसको treat कैसे करते हैं? Since they are formed in acidic pH, treatment is alkaline. Make the urine alkaline. Alkalinization of urine, 1, and 2, you give them allopurinol. जो गाउट का ट्रीटमेंट है, एलोप्यूरिनॉल इनको देते हैं. और आखिरी किडनी स्टोन्स जो होते हैं वो होते हैं, जो रेयर होते हैं, वो होते हैं सिस्टीन स्टोन्स. दे आर cystine stones. Again, they are formed in decreased pH, and cystine stones, like uric acid, they are radiolucent. They are radiolucent, and again by X-ray they are radiolucent, and if you see them by CT, they are sometimes visible. Again, they are sometimes visible. They are sometimes visible. अच्छा, अगर corresponding crystals are found in the urine, what is the shape of the crystal? Crystals are hexagonal. They are hexagonal in shape. और cystine stones के cause क्या हैं? Hereditary. So cause of formation of cystine stones can be hereditary. Hereditary is autosomal recessive condition in which cystine reabsorbing PCT transporter, you know, cystine is reabsorbed in the proximal convoluted tubules. So in hereditary condition, the cystine reabsorbing PCT transporter loses its function. So cystine reabsorbing PCT transporter loses function. So its function is lost, and that is why cystine is not absorbed, and this results in cystinuria. Cystinuria and stone formation. So all this is seen in this, and this is usually hereditary. And these stones, they begin in childhood, and they can form. So begin in childhood. Stones begin in childhood. So these stones begin in childhood, and they can also form Staghorn calculi. Usually Staghorn calculi are ammonium magnesium phosphate stones, but these can also form Staghorn calculi. They can also form Staghorn calculi. So these are the various stones in the kidney that we see. Okay, so the next question I showed you was on the crystals. Next was on the crystals. So that is why, okay, now a 49-year-old African American male presents with history of CML, for which he is receiving chemotherapy, and presents to emergency room with oliguria and colicky flank pain. So creatinine is 3.3, which is what is the preferred preventive therapy that could be administered to this patient to prevent her complications of chemotherapy. So now please tell me the answer. This is high cell turnover. So since this is high cell turnover is there in CML, so uric acid stones are formed. Uric acid stones are formed. So now you know uric acid stones are formed in an acidic pH. So no role of steroids here, no role of dialysis, no role of acidification of urine. For uric acid stones, you will do alkalinization of urine, you will give them allopurinol, and you will ask them, for all the stones, you ask them to drink lot of water so that they pass lot of urine, and diuresis is there. Colchicine is not related to the stone. So answer is diuresis. अच्छा, अब यहाँ देखो, अब सभी stones की shapes थी. Uric acid stone, these are uric acid stones. So these are the crystals now. So uric acid crystals. So crystals in the urine, these are uric acid crystals. Uric acid crystals are rhomboid in shape. Rhomboid, or they are like rosettes. अच्छा, फिर calcium phosphate. Calcium phosphate Calcium phosphate crystals are prism shaped. This is the crystal. This is prism or wedge shaped. So they are prism or wedge shaped. Then magnesium ammonium phosphate crystals, which are formed in alkaline urine. So uric acid are formed in acidic urine. Calcium phosphate are formed in alkaline urine. Magnesium ammonium phosphate are also formed in alkaline urine, and they have this is coffin lid shape. This is the coffin lid shape. Then calcium oxalate crystal. This is formation is independent of urine pH, and these are, if you see the shape, these are envelope shaped. This is these are envelope, or they may be dumbbell shaped, envelope shaped crystal. So ये दोनों calcium oxalate crystals हैं, envelope या dumbbell shaped. So calcium oxalate crystals can be envelope shaped or they can be dumbbell shaped. And last is cystine. Cystine are hexagonal crystals. So these crystals are hexagonal in shape. So these are hexagonal crystals of cystine. Okay. Achha, this is the picture of kidney showing hydronephrosis. So the whole pelvic ileal system. What is hydronephrosis? Dilatation of the pelvis and pelvic ileal system is hydronephrosis, and hydronephrosis usually is due to urinary tract obstruction. Urinary tract, so hydronephrosis. So what is hydronephrosis? Dilatation of the renal pelvis and the chelicus is hydronephrosis. So dilation of pelvis and chelicus is called hydronephrosis. Cause of hydronephrosis क्या है? Urinary tract obstruction due to any cause. So obstruction can be due to stones. Obstruction can be due to benign hyperplasia of prostate. CA cervix patients can also have urinary obstruction, which can cause this. So all these can cause hydronephrosis. Okay. So this is hydronephrosis of the picture of hydronephrosis of the kidney. Okay. Now we will come to pyelonephritis. Okay. Now we will come to pyelonephritis. Okay. So now coming to so we'll see first UTI. UTI. What is UTI? Urinary tract infection. Urinary tract infection. So infection of the urinary tract. Now UTI can be asymptomatic. Patient has no symptoms. Or it can be, so this can be asymptomatic. So asymptomatic, or it can be symptomatic. Symptomatic. And it encompasses, what all do you see in UTI? So it can be asymptomatic, just asymptomatic bacteria. So it can be asymptomatic bacteria. So just bacteria are in the urine. There's infection in the urine, but the patient does not have any symptoms. Second, now the bladder, because of infection, bladder is getting inflamed. So acute bacterial cystitis. Acute bacterial, so urinary tract infection encompasses. So what all does urinary tract infection include? So urinary tract infection includes, number one, asymptomatic bacteria. 2, acute bacterial cystitis. That is, now the inflammation, bladder is getting inflamed. Prostatitis. Prostate can get inflamed. And 4th, infection can reach the kidney, causing inflammation of the kidney. That is called acute pyelonephritis. Pyelonephritis. So urinary tract infection includes just simple asymptomatic bacteria, acute bacterial cystitis, prostatitis, or acute pyelonephritis. Okay, now let us come to acute bacterial cystitis. So acute bacterial, so we'll be discussing bacterial cystitis and pyelonephritis. So coming to acute bacterial cystitis. So you know what is cystitis. So this is the acute bacterial cystitis. This is the inflammation of urinary bladder. Acute inflammation of urinary bladder. So bladder is inflamed, and clinical features, how will they present if the bladder is inflamed? There will be suprapubic pain. So bladder is located in the suprapubic region. So suprapubic pain, dysuria. So dysuria, burning sensation while passing urine, urinary frequency, again and again passage of urine, urinary frequency and urgency. Urinary frequency, urinary urgency. And systemic features क्या होंगे? The patient can have systemic signs. So systemic signs, patient can have fever. So patient can present with high fever and chills. High fever and chills. Systemic signs usually they plus minus हैं, may or may not be present. And what is the cause? Cause is most common is bacteria, that is E. coli. Most common is E. coli. So this is most common. In addition to E. coli, now we also have Staphylococcus saprophyticus. Staphylococcus saprophyticus. Staphylococcus usually a sexually active young women में मिलता है. Staphylococcus saprophyticus. This is seen in sexually active young women. So sexually active young women, and then of course Klebsiella and Proteus. So Proteus, all these organisms can cause this. अच्छा, अब lab findings में क्या होगा? Laboratory studies में, lab findings में, number one, now you will find WBCs in the urine. So you will find WBCs in the urine, and a test for WBCs is leukocyte esterase. ये जो WBC का एंजाइम है यूरिन में, जो हम डिपस्टिक से डिटेक्ट कर सकते हैं. So when you put dipstick in the urine, it will be positive for leukocyte esterase. So that tells you that there are WBCs in the urine. Second, nitrites will be positive. Nitrites, urine will also test positive by dipstick for nitrites. अच्छा, nitrites कब आएंगे? It indicates infection with gram-negative organism. So gram-negative infection indicates gram-negative infection. Normally यूरिन में nitrates होते हैं, NITRATES, nitrates होते हैं. तो जब urinary tract infection हो जाता है, gram-negative बैक्टीरिया आते हैं, वो nitrates को nitrites में convert कर देते हैं. So nitrites, they produce enzyme that converts nitrates to nitrites. And third, urease positive. Urine will be positive for enzyme urease. Urease positivity suggests Streptococcus proteus and Klebsiella infection. So Streptococcus proteus and Klebsiella infection. So that is indicated by nitrites. Nitrites indicate gram-negative infection, especially E. coli. And urease positive indicate Klebsiella. So if urine is testing urease positive by dipstick, it can be due to Klebsiella, staph or Proteus. Proteus is there. Okay, then you do urine, this is urine dipstick, then urine will show WBCs, more than 10 WBCs per ml. More than 10 WBCs per ml, plus you may see WBC casts. WBC casts may be present in the urine. And of course, urine culture is the gold standard for diagnosis. So you will have to culture the urine, find out which organism is causing it, and also do a sensitivity. So urine culture will be diagnostic. Okay, so urine culture is diagnostic. So this is acute bacterial cystitis. Now let us come to very important pyelonephritis. Acute pyelonephritis. Okay, the infection was in the bladder. Now the infection reaches the kidney. Okay, now if you see, the infection can reach the kidney by two ways. So this is pyelonephritis. The infection can reach the kidney by two ways. Number one, most common is ascending infection. Ascending infection, that is from the urethra, the infection reaches the bladder. From the bladder, the infection goes through the ureters into the kidney. And the common, this is most common mode of infection reaching the kidney, and the organisms are E. coli, Proteus and other enterobacteria. Second, infection can also reach the kidney by hematogenous route. And in hematogenous route, the common agents are Staphylococcus and E. coli. Now this is how acute pyelonephritic kidney looks like. This is, see, there are these multiple abscesses in the kidney. So in acute pyelonephritis, you can see these areas. These are the surface of the kidney is studded with these multiple abscesses. So abscess, pus containing pockets form on the surface of the urine. So this is acute pyelonephritis. So what is acute pyelonephritis? So pyelonephritis. So acute pyelonephritis क्या होता है? In the kidney, in the tubules of the kidney and in the interstitium of the kidney, there is acute inflammation of the tubules and interstitium caused by bacteria. So what is acute pyelonephritis? Acute inflammation. Acute inflammation के सेल कौन से हैं? Neutrophils. So what is pyelonephritis? Acute inflammation of tubules and interstitium. So in the tubules and the interstitium, what do you see? You see neutrophils. So what is the definition of pyelonephritis? Acute pyelonephritis, acute inflammation that is the kidney. Of which part of kidney? Tubules and the interstitium. They are infiltrated by these by the neutrophils. Glomeruli are spared. So glomeruli are spared. Now acute pyelonephritis, it affects the cortex. So it affects cortex, affects tubules and interstitium of the cortex. So affects cortex, glomeruli and vessels, and blood vessels of the kidney are spared. Vessels are spared. So cortical tubules, in the cortex of the kidney, the tubules and interstitium will get inflamed. अच्छा, अब clinical feature pyelonephritis का कैसे present करते हैं? Patient will have fever, will have flank pain. Kidneys are located in the flank pain, and fever, flank pain. Then they may have nausea, moment fever with chills may be there, and they may also have nausea or vomiting. Vomiting may be there. Achha, how does the infection reach the kidney? I have already told you, infection reaches the kidney by two routes. Reaches the kidney by two routes. Number one, ascending infection, which is more common, and the organism here is usually E. coli. And second is hematogenous route. The infection reaches the kidney by hematogenous route, and by hematogenous route, staph, and again E. coli. These are the common organisms. More common route is the ascending infection. Okay, now risk factors क्या है pyelonephritis के? Risk factors are, number one, people who have indwelling catheters. People with indwelling catheters, or urinary tract obstruction due to stones or cancer, any cause of urinary tract obstruction. Third, patients with diabetes mellitus are prone to develop UTI and pyelonephritis. Pregnancy, because the pregnant uterus presses on the ureters and it causes urinary tract, it can cause obstruction. And then an entity called as vesico-uretral reflux. All these can cause infection, or these are risk factors for infection reaching the kidney. Causative organisms we already know. They are usually gram-negative bacteria. I have already told you, same as we read in acute bacterial cystitis. E. coli, Streptococcus, Staphylococcus, Klebsiella, Proteus. Urine analysis findings all will be the same. Okay, now what are the complications of acute pyelonephritis? Complications are acute, बार-बार अगर किसी को acute pyelonephritis होगा, that can progress to chronic pyelonephritis. Acute can go to chronic. Second complication, the whole renal pelvis may become full of pus. That is called pyonephrosis. So the pelvic ileal system becomes full of pus. Third, this is the kidney. Outside the kidney, what is there? This is perinephric fat. So now infection from the kidney can go into the perinephric fat and cause perinephric abscess. And last, it can also cause papillary necrosis. You know what is papilla? I have already told you, tips of the distal 2/3 of the pyramid, medullary pyramids is called papillae. So papillary necrosis, renal papillary necrosis can also happen. Or treatment क्या है? Acute pyelonephritis का antibiotics. Acute pyelonephritis का treatment है, patient has to be given antibiotics. Okay, now next entity. So this is again, these are simple. Next is chronic pyelonephritis. Okay, now chronic pyelonephritis is recurrent episodes of acute pyelonephritis. So recurrent episodes of acute pyelonephritis can progress to chronic pyelonephritis. So recurrent episodes of acute can progress to chronic. And this chronic pyelonephritis, there can be two predisposing causes. Number one, chronic obstruction. So chronic obstructive pyelonephritis. This is due to a long-standing obstruction which is causing repeated attacks of acute pyelonephritis. So this can be a calculus This can be BHP, benign hyperplasia. So this can be stones in the kidney. This can be due to stones. This can be due to benign hyperplasia of prostate, which is causing obstruction, or this can be due to posterior urethral valves, which may be seen in children, which is a congenital anomaly which can be seen in children. Second can be chronic reflux pyelonephritis. Chronic reflux pyelonephritis. So second cause of chronic is chronically the urine is getting there is reflux of urine into the kidney. So there is reflux from the bladder, it is going back into the kidney. So this is the most common cause of chronic pyelonephritis. Most common cause of chronic pyelonephritis, and this is seen usually in case of vesico-uretral reflux. Vesico-uretral reflux. So there is something called as congenital vesico-uretral reflux. There is something called as congenital vesico-uretral reflux, that is between the bladder, where the ureters come into the bladder. There is a valve there. So that valve is weak. So that valve is weak, and as a result, whenever the urine in the bladder increases, since the valve is incompetent, the urine goes back through the ureters and reaches the kidney. So it reaches the kidney. So that is called as chronic reflux pyelonephritis. So chronic pyelonephritis can be due to obstruction, which is called chronic obstructive pyelonephritis, or it can be chronic reflux pyelonephritis, which is due to congenital vesico-uretral reflux. Okay, now if you look at the kidney, gross is very characteristic. जब pyelonephritis हो जाता है तो kidney कैसी हो जाती है? Kidney is reduced in size. Number one, it is reduced. Both the kidneys may be involved, so they are asymmetrically contracted. The kidneys are reduced in size, they are contracted, and they are scarred. So you have a contracted scarred kidney. अच्छा, अब स्कार की डिस्क्रिप्शन बहुत इंपॉर्टेंट है. कैसी है? कैसा स्कार है? बहुत बड़ा स्कार है. इट्स अ कॉर्टिकोमेड्यूलरी स्कार. सो व्हाट टाइप ऑफ स्कार इज इट? इट इज द scars are corticomedullary. So they extend from the cortex, they extend from the medulla to the cortex, and these scars, they sit on a blunted calyx. Scars sit on a deformed or a blunted calyx. So scars sit on a blunted calyx. Okay. Under the microscopy, very important feature, one line you have to remember. If you look at the tubules, so if you look at the tubules, so in pyelonephritis also tubules and interstitium is involved. No glomerular involvement. Glomerular involvement is less common. Okay, now if you look at so glomerular involvement is usually not seen. So what do you see? Tubules. Number one, look at the tubules. Tubules show thyroidization. There is thyroidization of tubules. So now what do I mean by thyroidization? Thyroidization means there is pink material in lumen of tubules. Which looks like colloid. गुलाबी रंग का मटेरियल मिलता है ट्यूब्यूल्स के लूमेन में, जो कि बिल्कुल कोलॉइड की तरह लगता है. इसको हम कहते हैं थायरॉइडाइजेशन ऑफ ट्यूब्यूल्स. एंड सेकेंड, देयर इज interstitial fibrosis. There's interstitial fibrosis. That is why the kidney becomes small and contracted. Achha, now there's a special type of chronic pyelonephritis called as xanthogranulomatous pyelonephritis. There is a special type of chronic pyelonephritis called xanthogranulomatous pyelonephritis. This is rare, one. And two, what is the characteristic feature of xanthogranulomatous? There is a lot of kidney damage. There is granulomatous inflammation. So xanthogranulomatous means there is granulomatous inflammation with numerous macrophages. So the interstitium, the kidney shows granulomatous inflammation. With foamy macrophages. Granulomatous inflammation with foamy macrophages. And cause, usually it is caused by E. coli or Proteus. Can cause this xanthogranulomatous pyelonephritis, E. coli or Proteus. So this is xanthogranulomatous pyelonephritis. We will cover one more entity before We finish? Okay. Okay, now this is chronic pyelonephritis. This is the chronic pyelonephritis. These are the coarse scars. So see, this is a cortical scar. The scar is from the cortex to the medulla, and below that the calyx is completely blunted. So it is sitting on this blunted. The calyx has become blunted like this. So it is sitting on a blunted calyx. No, multiple abscesses. Abscess contain neutrophils. Neutrophils will be seen in acute pyelonephritis. This is acute pyelonephritis. See, this is acute pyelonephritis. You are seeing these multiple abscesses. और किडनी का acute pyelonephritis में किडनी का साइज नॉर्मल होगा, लेकिन किडनी के सरफेस पे एब्सेस बने होंगे. एब्सेस किस चीज से बनते हैं? एब्सेस न्यूट्रोफिल. Abscess is liquefactive necrosis and it contains neutrophils. So these are abscesses which are full of neutrophils. Okay, and chronic pyelonephritis में क्या होगा? स्कार्स बनेंगे किडनी पे, माइक्रोस्कोपी में टिब्यूल्स में थायरोडाइजेशन होगा, इंटरस्टिशियम में फाइब्रोसिस और क्रॉनिक इन्फ्लेमेशन होगा, एक्यूट इन्फ्लेमेशन नहीं होगा. Okay, so this is the kidney. Okay, now look at this question. A 4-year-old male is accompanied by his mother to the pediatrician. His mother reports that over past 2 weeks the child has intermittent low-grade fever and is more lethargic. The child's past medical history he has a meningomyelocele complicated by lower extremity weakness as well as bowel and bladder dysfunction. So the child is having meningomyelocele with extremity weakness and lower bowel and bladder dysfunction. He has been hospitalized multiple times at an outside facility for recurrent UTI. Then the child is in the 5th percentile for weight and height. Temperature is, he has fever. Blood pressure is 115/70. Pulse is increased 115 per minute. Respiratory is 20. Physical examination is notable for cortovertebral angle tenderness, which is worst at night. Which of the following is likely to be found in the biopsy of the patient? So which of the following is found to be positive in biopsy of the patient? So what is the answer to this? What is the answer to this? Please tell me the answer. What do you think is the answer to this question? What is the answer to this question? परविंदर, मुस्कान, उज्जवल, रिंजिन, यालिनी, प्रीति, आंसर सोचो इसका, सब लोग बताओ. ओके, ऑप्शन ए देखो, मोनोन्यूक्लियर एंड इओसिनोफिलिक इन्फिल्ट्रेट. अभी हम पढ़ेंगे समथिंग कॉल्ड एज एक्यूट इंटरस्टिशियल नेफ्राइटिस या एक्यूट इंटरस्टिशियल नेफ्राइटिस. So there's something called as acute interstitial nephritis. In acute interstitial nephritis, you have mononuclear and eosinophils in the kidney, and mononuclear cells mean lymphocytes and macrophages, and eosinophils in the kidney are seen in acute interstitial nephritis. Replacement of kidney parenchyma by foamy histiocytes. This is seen in xanthogranulomatous pyelonephritis. अभी हमने पढ़ा था. Third, destruction of PCT and thick ascending limb. This is seen, destruction of PCT and thick ascending limb. This is seen in ATN, acute tubular necrosis, which we will read. Acute tubular necrosis, where there is necrosis or destruction of the. Then diffusely necrotic papillae with dystrophic calcification is seen in papillary necrosis. Papillary necrosis. So answer to this is last, tubular colloid casts. Tubular colloid casts with diffuse lymphoplasmacytic infiltrate. So this is chronic pyelonephritis. History of chronic pyelonephritis. The child has reason for chronic pyelonephritis. He has bladder dysfunction, and because of that bladder dysfunction he has recurrent UTI. So now he has developed chronic pyelonephritis. So tubular colloid casts, these are in the tubules, there are colloid casts. These are thyroidization of tubules. And you know, in chronic pyelonephritis, what do you see? You see, number 1, thyroidization, 2, interstitial fibrosis, interstitial fibrosis, and 3 chronic inflammation in the interstitium. That is, what is the chronic inflammation? Interstitial, you see in the interstitium you see lymphocytes and plasma cells. So yes, Muskan answer is right. It is E. Parminder also it is E. Correct. So this is and chronic inflammation, that is diffuse lymphoplasmacytic infiltrate in the interstitium. These are the features of chronic pyelonephritis. So answer to this is E. Okay. Okay, now let us come back. Okay, this we will see later. This question will come later. Okay, now just 1 or 2 things. Number 1, now what is glomerulonephritis? You know, inflammation of the glomerulus. Inflammation of the glomerulus. So just a few things to clarify. Inflammation of the glomerulus is glomerulonephritis. Okay, so glomerulus हो गया. अब kidney में क्या क्या है? Nephron के क्या क्या है? Nephron has a glomerulus. What does nephron contain? A glomerulus. Inflammation of glomerulus is glomerulonephritis. Is inflammation of glomerulus. अच्छा, दूसरा पार्ट क्या है? नेफ्रॉन का tubules है. और tubules it has tubules. Now the nephron lies in a background of interstitium. So now what is tubulointerstitial nephritis? So what is tubulointerstitial nephritis, which is also called TIN? What is tubulointerstitial nephritis? So inflammation of the glomerulus is glomerulonephritis. Inflammation of tubules and interstitium is called tubulointerstitial nephritis. So what is tubulointerstitial nephritis? Inflammation of the tubules and interstitium is tubulointerstitial nephritis. अच्छा, अब जो पाइलोनेफ्राइटिस है, what is acute पाइलोनेफ्राइटिस? 2 पढ़े थे, acute and chronic. पाइलोनेफ्राइटिस में भी किसकी इन्फ्लेमेशन हो रही है? पाइलोनेफ्राइटिस is also inflammation of tubules and interstitium caused by bacteria. So when inflammation of tubules and interstitium is caused by bacteria, we use the term pyelonephritis. Otherwise, if there is inflammation of tubules and interstitium due to other reasons, we call it tubulointerstitial nephritis. Okay, so inflammation of the glomerulus is glomerulonephritis. Inflammation of the tubules and interstitium is inflammation of tubules and interstitium caused by bacteria is pyelonephritis, which can be acute or chronic, and inflammation of the tubules due to other reasons is called tubulointerstitial nephritis. So now let us see acute interstitial nephritis, or which is also called as tubulointerstitial nephritis, TIN. So what is acute TIN? Okay, now what is acute tubulointerstitial nephritis? It is acute inflammation of the interstitium, and it is usually immune mediated. So this is acute. So I told you, if it is caused by bacteria, you will call it pyelonephritis, but if it is due to other causes, you will call it as acute tubulointerstitial nephritis. So acute immune mediated, it's acute immune mediated inflammation, acute immune mediated inflammation of tubules and interstitium, that is called as acute tubulointerstitial nephritis. अच्छा, now usually you know acute tubulointerstitial nephritis के causes क्या है? Very important cause is drug induced. You know, drugs, they act as heptens, HAPTENs. Drugs act as heptens, and in response to drug induced hypersensitivity. So in response to drugs, the immune reaction is produced, and this is usually a type 4 hypersensitivity reaction. So it is due to type 4. It is a type 4 hypersensitivity reaction. अच्छा, यहाँ पर drugs के नाम याद करने हैं आपको. So remember the P's. So which are the drugs? Number 1, diuretics. Diuretics. Number 1, diuretics. Number 2, pain free. Second is pain free. So ये कौन सी drug है? NSAIDs. So the drugs that cause are diuretics, the P's, then third P is for penicillin, penicillins and cephalosporins. So this is a penicillin and cephalosporins. Then proton pump inhibitors, proton pump inhibitors, proton pump inhibitors, and last very important is rifampicin. Of course there is rifam, again इसको याद करने के लिए P, rifampin or rifampicin, and one more drug, add sulfonamides, which is not P, so add sulfonamides. So the drugs that cause tubulointerstitial or tubulointerstitial nephritis are, it's a type 4 reaction, it's caused by diuretics, NSAIDs, penicillin, cephalosporin, proton pump inhibitors, rifampin, sulfonamides. Okay, second, penicillin and sulfonamide. Less commonly, other causes. Okay, other causes, it can be due to systemic infections. Systemic infections. So systemic infections can also cause tubulointerstitial nephritis. Example, mycoplasma infection. Or third, it can be due to autoimmune diseases. It can be due to autoimmune diseases like Sjogren syndrome, autoimmune diseases like SLE, Sjogren syndrome, etc. It can be due to SLE, Sjogren syndrome, etc. Now clinical features. Now very, very important is drugs. So when it is associated with drugs, clinical features, so drug induced, patient has fever, so fever, maculopapular rash. So patient presents with fever, maculopapular rash, hematuria, and they have hematuria, oliguria, and they may also present with costovertebral angle tenderness. So they may also present, or they can be at times be asymptomatic also. So they can be asymptomatic also. Now important, very, very important point which you have to learn up for diagnosis. They have, a patient has classically urine examination, there is pyuria, that is pus in the urine, pyurine, and classically there are eosinophils. You see presence of, so drug induced में मिलते हैं. So urine has neutrophils, WBCs, and very important is eosinophils. There are eosinophils. So there is eosinophils as well. So there is in the urine. So in the urine you have eosinophils in the urine. How will you see eosinophils in the urine? By right stain. अच्छा, neutrophils तो क्या है? यूरिन में eosinophils मिलेंगे, तो यूरिन में WBC casts मिलेंगी. So neutrophils की casts मिलेंगी, WBC की casts मिलेंगी. और तीसरा यूरिन में hematuria होगा. There will be hematuria in the urine. So there's pyuria, there's WBC casts. Pyuria means WBC is pus in the urine, neutrophils in the urine. So neutrophils will be seen as WBC casts. Eosinophils will be seen in the urine by right stain. There will be hematuria. Then blood. If you do blood examination, if you do a CBC, complete blood count, patient will have eosinophilia. Eosinophil count in the blood will be increased. There will be eosinophilia. Then serum creatinine will be, and urea and blood urea nitrogen, they will also be elevated. So azotemia bhi ho gaya, blood urea nitrogen will also be elevated. So this is what you see in tubulointerstitial nephritis. So very important, this is what we see in tubulointerstitial nephritis. Achha, now there is an entity called as, हमने पढ़ा था renal papilla क्या होता है. So there is something called as renal इसके causes आने चाहिए, renal papillary necrosis. So renal papillary necrosis. So what is, you know what a papillae? So papillae is this is the renal pyramid. The distal 2/3 part is called the papilla. Now this can undergo necrosis. So what is necrosis? So necrosis of the, so what is renal papillary necrosis? So the papillae slough off. Cause of renal papillary necrosis. Cause is very sad. SAAD, sad. So this is sickle cell disease. 1, 2 acute pyelonephritis, हमने इसकी complication पढ़ी थी. renal papillary necrosis, nephritis, then analgesics like NSAIDs can cause it, and D stands for diabetes mellitus. Diabetes mellitus. All these can cause renal papillary necrosis. And how will the patient present? There will be urine mein patient will have hematuria and proteinuria. Hematuria and proteinuria. So hematuria and proteinuria. This is renal papillary necrosis. Renal papillary necrosis. Okay, now we will look at one or two questions here. अच्छा, अभी ATN नहीं कवर हुआ है. Okay, this is also ATN. Okay, so this is about acute tubulointerstitial nephritis. Okay, now next topic that I have to cover is acute tubular necrosis. Now from kidney I am left with acute tubular necrosis, little bit about cysts in the kidney and tumors of the kidney. So now just definition before we finish. Acute tubular necrosis I will do in the next class. So renal cysts and renal tumors I will cover in all these three topics. I will cover in the next class with questions. Just 2 lines which you have to know: what is acute kidney injury, what is chronic kidney injury, or what is chronic kidney disease or acute kidney disease. So what is acute kidney injury? What is acute kidney injury? AKI. What is acute kidney injury or AKI? What is acute kidney injury? This is abrupt decline in renal function. So what is acute kidney injury is defined as, so what is the definition? Suddenly the renal function deteriorates. So there is abrupt decline or abrupt decline in renal function. Renal function. So that is called acute kidney injury. That is, the kidney gets injured, so renal function is declined as seen by. So how will you measure it? Due to increased creatinine and BUN. So a rapid decline in renal function with azotemia. With azotemia. So increased BUN, increased creatinine. So rapid decline in abrupt decline in renal function. And how do you know the renal function has declined? Patient has developed increased BUN and अच्छा, causes क्या है acute kidney injury के? AKI के causes can be pre-renal, cause outside the kidney, that is damaging the kidney. Cause can be in the kidney itself and cause can be post-renal. So pre-renal causes include, pre-renal means kidney due any cause which is leading to hypotension. Kidney is not getting enough blood, so there is cause is hypotension. Hypotension due to any reason, as in shock or hypovolemia or shock. So hypotension can be as in, so kidney is not getting enough blood, there is hypotension. So this can be due to shock, this can be due to dehydration or any other cause. So hypotension, this is pre-renal cause of acute kidney injury. Second is renal cause. Renal cause, अच्छा, renal cause में क्या क्या आता है? In renal cause we have acute tubular necrosis, ATN causing injury. Acute glomerulonephritis can cause rapid deterioration of renal function, and acute interstitial nephritis, acute tubulointerstitial nephritis, acute TIN can also cause acute renal failure. Acute kidney injury, the old name for this was acute renal failure. Now we prefer the term acute kidney injury to acute renal failure. So acute kidney injury is equal to acute renal failure, same thing. So acute renal failure क्या है? Abrupt decline in renal function with increase in BUN and creatinine. Cause of acute renal failure can be pre-renal cause, when kidney doesn't get enough blood or when there is dehydration, enough blood नहीं आता, shock में, other causes में. Second, renal cause can be acute tubular necrosis, acute glomerulonephritis or acute tubulointerstitial nephritis. And then post-renal causes. Post-renal cause can be obstruction to the outflow. Obstruction to outflow of urine. So obstruction to the outflow of urine can be seen in renal stones, So this can be due to stones. You already know the causes. This can be due to benign hyperplasia of prostate. This can be due to cancers. Obstruction to the outflow of urine can be due to various cancers, or it can be due to congenital anomalies of the urinary tract also. All can cause obstruction. So this is acute renal failure or acute kidney injury. Similarly, we have something called as chronic renal failure or chronic kidney injury. Chronic renal failure. Another name for this is chronic CKI, chronic kidney CKI or chronic kidney injury. AKI and CKI, chronic kidney injury. So what is this? This is slow loss of renal function. So this is renal failure occurring slowly. So progressive nephron loss. So progressive loss of nephrons. So the functional unit of the kidney, that is the nephrons, are lost. Progressive loss of nephrons resulting from any type of kidney disease, due to any type of kidney disease. So any type of kidney disease is resulting in progressive loss of renal function. So in chronic kidney disease, so when there is chronic renal failure or chronic kidney disease, if you look at the kidney, if you look at the grossly, if you look at the kidneys, we have granular contracted kidneys. Contracted kidneys. So there is slowly the nephrons are getting lost, the kidney size is reducing, and the kidneys have a granular surface. So under the microscope, what will you see in chronic kidney disease? What will happen to the kidney? This is an end stage kidney disease. So now what do you see? The glomeruli are lost. There is sclerosis of glomeruli. There is sclerosis of glomeruli. 1, 2, there is atrophy of tubules. So tubules, glomeruli are gone, tubules are gone. And third, look at the interstitium. There is interstitial fibrosis. So interstitium also undergoes fibrosis. And fourth, even the vessels, blood vessels of the kidney now become obliterated. So there is sclerosis of the fibrosis of blood vessels also. So all these features are seen in chronic kidney disease or chronic kidney injury. Okay, so these are the causes of acute and chronic renal failure. So acute kidney injury or acute renal failure, and chronic kidney injury or chronic renal failure. Okay. And so now in the next class we will discuss ATN. What is ATN? ATN leads to acute renal failure. So ATN is acute tubular necrosis. Okay. So this is what, so in the next class I will be covering acute tubular necrosis, cysts of the kidney and tumors of the kidney. So now if you have any questions, okay, Muskan had asked me the question. मुस्कान ने पूछा था C3 levels के बारे में. अच्छा, I'll go back to that part again. Okay, now you would ask me about C3. Okay, now remember we read about acute post-streptococcal, IgA nephropathy, diffuse proliferative, RPG and MPGN. Okay, now remember in all these glomerulonephritis, immune complexes are there. Okay, now what does an immune complex contain? It contains antibody plus immune complex also contain complement component. If immune complexes are formed, antibodies are used up, complement is used up. So when complement is used up, serum levels of complement blood levels of complement will fall down. अच्छा, अब acute post-streptococcal glomerulonephritis देखो, उसमें जो immune complexes बनते हैं किडनी में, जो subepithelial deposit होता है जिनका, they contain IgG antibody, IgM antibody and C3. So since C3 is getting used up and is getting deposited in the kidney, blood levels of C3 complement component will fall down. Then in IgA nephropathy, now you know C3 can come from classical pathway or C3 can come from alternate pathway. in most of the diseases, C3 is coming from the classical pathway. Only in two conditions, IgA nephropathy and MPGN type 2, C3 that is getting deposited in the kidney comes from the alternate complement pathway. Okay, so that is what I am trying to tell you. So in IgA nephropathy, what is deposited in the kidney, and IgA antibody along with C3 of alternate complement pathway is getting deposited in the kidney. Blood level of C3 may fall, may not fall. Third, in diffuse proliferative glomerulonephritis, IgG and C3 of classical pathway is depositing in the kidney, and C3 levels in the blood may fall down. Fourth, in membranoproliferative glomerulonephritis type 1, IgG antibody along with C3 of classical pathway is deposited in the kidney. Blood C3 levels are usually normal. In MPGN type 2, no antibody deposition, only C3 of alternate complement pathway is getting deposited in the kidney. Plus, in type 2, serum C3 levels are decreased and these people have C3 nephritic factor in their blood. So, C3 इम्यून कॉम्प्लेक्सेस में C3 डिपॉजिट होता है किडनी में. जब भी इम्यून कॉम्प्लेक्सेस डिपॉजिट होते हैं C3 भी होता है, तो ब्लड का C3 लेवल भी, इफ द C3 is getting deposited in the kidney, it is getting consumed, blood C3 levels, serum C3 levels may fall down. So in acute post-streptococcal, serum C3 levels fall down. In diffuse proliferative, serum C3 levels fall down. And in type 2 MPGN, serum C3 levels will fall down. So is it clear, Muskan? Okay, now I'll stop the class here. All of you, if there is any query about anything in the pertaining to this topic, do ask, because the kidney is a very, very important topic. You should understand everything in the kidney properly. So suppose किसी की कोई और queries हैं तो please पूछ लो. मुस्कान, परविंदर, उज्जवल, प्रीति. Can we finish the class now? नहीं, alternate C, okay, Muskan, whether it is classical C3 or alternate C3, whether it is classical C3 or alternate C3, if C3 gets consumed, serum C3 levels may be decreased, but not always. For example, in acute post-streptococcal, classical C3 is found in the deposits and serum C3 is also reduced. In diffuse proliferative, again, classical C3 is found in the deposits and serum C3 is reduced. In IgA nephropathy, IgA antibodies along with alternate C3 is found in the deposits, but serum C3 is not reduced. Whereas in MPGN, then look at MPGN type 1 and type 2. In MPGN type 1, IgG plus classical C3 is there in the deposits, but serum C3 is not reduced. Whereas in type 2, there is only C3 of alternate pathway and serum C3 is also reduced. So ऐसा नहीं है कि अगर वो alternate का C3 है तो serum में reduce नहीं होगा. Yes, blood levels. So this is not how, this is actually, this C3, this is variable because it is amount of C3 that is getting consumed in those deposits. So in acute post-streptococcal, the amount of C3 का लेवल ब्लड में कब फॉल होगा? ये तब फॉल होगा जब बहुत सारा C3 डिपॉजिट्स में कंज्यूम हो जाएगा, तो सीरम C3 विल फॉल. तो अगर कम कंज्यूम होगा तो कम फॉल होगा. एक्यूट पोस्ट स्ट्रेप्टोकॉकल में ज्यादा कंज्यूम हो जाता है, इन एमपीजीएन टाइप 2 में ज्यादा कंज्यूम हो जाता है डिपॉजिट्स में, इसीलिए देयर इज अ फॉल इन दी सीरम C3 लेवल. So it is how much amount of C3 gets consumed. So it has been observed that in these the amount of C3 level consumed is much more. That is why the serum C3 level falls down. Okay, any other question? Okay, so I'll end the class here. Good night everyone. Read up the topic properly and we'll continue with this next time and start with a new one.